Hello, check. Hello, 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 check. Hello, 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 hello. Check. Hello, 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 check. Hello, check. Hello, hello. Mic testing check. Hello, check. Hello, check. Mic testing check. Hello, 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 check. Hello, mic testing check. Hello, 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 check. Hello, mic testing check. Hello, hello.
journey from the technical foundations of ANE testing in the laboratory to its clinical implications at the bedside. We have with us today eminent experts in microbiology, rheumatology, and nephrology and laboratory diagnostics who will share their expertise and practical insights. Without further delay, let us begin the academic session for the day. I request all the delegates to please submit their pre session questionnaire. To begin the scientific deliberations of the day, we have an insightful session on the foundation and methodology of ANA testing. This talk will explore key concepts including the debate between IIF, ELISA, and multiplex bead arrays in determining the gold standard for ANA detection. Before we proceed further with the academic sessions, we now move to the formal inauguration of this CME workshop. I take great pleasure in inviting our esteemed dignitaries onto the dais. It is our great honor and privilege to welcome our beloved Dean, Dr. D. Lakshmi Lalita Madam, onto the dais. Her inspiring leadership continues to guide and motivate us all. We are truly grateful to have you here, ma'am. We warmly welcome Dr. K. Sudhir Sir, Medical Superintendent and Director of Academics of GEMS. His vision has shaped the academic pattern we proudly uphold today. We now invite our dynamic professor and head of Department of Microbiology, Dr. Nitin Mohan Sir. Now I take the privilege of welcoming Dr. C.H. Kiran Kumar Sir, Observer, Andhra Pradesh Medical Council for the CME, onto the dais. It's an honor to have you here, sir. With the immense respect, we invite Dr. V. Ramarao Sir, PG Academic Coordinator, onto the stage. Now we invite Dr. T. Lakshmi Kantan, Senior Marketing Manager, Everlife CPC Diagnostics. I would like to invite Dr. P.J. Naidu Sir, Professor and HOD Pathology Department, GEMS. It is my privilege to call Dr. Suguneshwari Madam, Professor of Microbiology, onto the dais. We would like to welcome them onto the stage with a big round of applause. Your presence adds today great value of academic bridging. We now begin this significant day with the auspicious lamp lighting ceremony, a symbol of wisdom and enlightenment. May I kindly request everyone to rise as we welcome our dignitaries for the lamp lighting ceremony. I invite Priya to sing the prayer song. I would request our esteemed dignitaries to proceed for the lamp lighting.
గణగణమునకు పతి అయినా గణపతి దొరకు జయం జయం గణగణమునకు పతి అయినా గణపతి దొరకు జయం జయం గణం గణం బీజగమే గణం అణువుల జీవుల గణం 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 బీజగమే గణం అణువుల జీవుల గణం గణం గణగణమునకు పతి అయినా గణపతి దొరకు జయం జయం మూలాధారము జీవగణం స్వాదిష్టానము సస్యగణం మణిపూరము సంపదల గణం అనాహతం బదివాయుగణం గణగణమునకు పతి అయినా గణపతి దొరకు జయం జయం గణపతి దొరకు జయం జయం
To begin the scientific deliberations of the day, we have an insightful session on the foundations and methodology of the ANA testing. This talk will explore key concepts including. Now I request our Dean Dr. D. Lakshmi Lalita Madam to speak a few words on this occasion.
So, very good morning and a warm welcome to all of you for this wonderful roadmap, I should say, because seeing the enthusiasm of Dr. Nitin while conducting this program, to conduct this program, it at one point of time I just had to take a step back and ask him to relax, because he was so interested in conducting this, and he thinks that we can really make a difference if we truly understand the importance of it. So at this juncture, I would like to also tell that this is the Autoimmune Awareness Month, and this, as a part of this awareness program for this month, we have planned for this, and I think it should definitely go in a big way, and every one of you should get benefited out of it. And at this point, I just want to add two more sentences: that advanced ANA testing, ANA profile 3 with DF770, that is being included in our regular diagnostics, and C3 and C4 testing we have already started. HLA B27 testing soon. We are going to do it on the TrueNat platform. So these are the new things which we would definitely like to understand and know. And once again, I congratulate the Department of Microbiology, headed by Dr. Nitin, supported by real support, I should say, Dr. Sugneshwari Madam, Chandrasekhar, and all the other people in the department. It's a great beginning, and definitely, I think in the field of molecular testing, we are definitely going to make our own mark, and GEMS would definitely head forward. And I think it will really make an example in the society. That's what I really wish for it, and wish this program a great learning session. Thank you.
Thank you, ma'am, for your wonderful speech. Now I request our medical superintendent and director of academics, Dr. K. Sudhir sir, to speak a few words.
Respected Dean, Dr. Lakshmi Lalita, and today's observer, and all dignitaries on the dais, and all the faculty members, and all the delegates who are attending this CME. A very good morning, and a very warm welcome to our institution for all the outsiders who are coming to attend this thing. We can divide this the evolution of the medical sciences or the healthcare in our country into two uh, into two divisions or two eras, two periods, I can say. What I call it is pre-technology era and post-technology era. We are in the post-technology era. We are, all of us are trained in a pre-technology era where very limited investigative facilities were available to make a diagnosis to the patient. With the post-technology era, there are rapid advances have come into all the investigations and all the laboratory diagnostics and the radiological investigations. That is facilitating the near correct or almost exact clinical diagnosis to be made with the patients in the present era. That's what the society is also expecting. In those olden days, if the doctor says you have some problem, you have a fever, I am here to control your fever, and definitely don't worry. I'm assuring you, your problem will be resolved, and take this medication. And if the doctor says that's all enough, that is was enough for the patient. He used to trust the doctor. He used to go back, and I never questioned what is the eh, a criteria giving for the particular disease drugs to him or her, and they used to trust and they used to get relief, and that's all. But the present scenario is different. The patient questions your diagnosis. Patient validates. Patient judges. Patient's attendants judge the physicians, doctors, healthcare facilities, and they will verify your advices. The era has changed. You might have given a clinical diagnosis, you have written something, you have advices from some drug, and after going out of the clinic, patient verifies everything in Google and comes back and express their concerns. That is the era. That's what we are in this post technology era. So why this situation has happened? Because patients' expectations have become big with the projection of the healthcare industry in this society. Government of India did not recognize the healthcare as was the industry for until some time back. To pump in more funds into the healthcare sector, the government of India recognized this as the healthcare industry. That facilitated them to draw loans and finances from the other agencies. Once the money is pumped into the sector, the diagnostic laboratories, the diagnostics, the high-end corporate healthcare sectors, hospitals have come into the play. So that is that really propelled the a static clinical scenario into a very dynamic, accurate diagnostic scenarios. So that made all these investigations available. When we started, we were finding it difficult to get a report of thyroid profile in Srikakulam. Every profile, every investigation is available not in Srikakulam, is available in Narasanapeta. Such a scenario changed, such as the dynamics, logistics have improved in such a way. So everything is available for everyone. It, along with that, it brought out the responsibilities of the healthcare providers. That means we people, doctors, paramedical people, nursing people, all these people, the responsibilities have become more and more, because we are supposed to bring out the accurate diagnostic helpful things to the clinician. So the clinicians are supposed to make an accurate diagnosis. Yes, facility is available, manpower is available, but where is the ability to do it? To refine the skills of the our manpower, either the doctors or paramedics or nursing people. We need to train them. So in that process, these workshops are playing a major role, and the institutions, the managements, the governments are now focusing on the more and workshops, training, skill developments, and all those things. You might be hearing all these things here in the papers. Skill development everywhere, wherever you go, you say people say skill development, from our CM to anybody else. So the skill development is of a very paramount importance in making our work more fruitful, useful, and more relevant to the present day generation. So I really appreciate Dr. Nitin Mohan for taking a very uh, bold initiative to conduct this workshop. And refine the present clinical diagnostic skills of our clinicians and our paramedical people. And at the same time, he's focusing to help the other institutes, other faculty, making the other institute members also to utilize this workshop. I think I really congratulate you, Dr. Nitin, and I wish he should keep on doing this sort of workshops hereafter and mm, stand like an inspiring HOD for our institution. Thank you for giving me this opportunity.
Thank you, sir, for your thought provoking words. Now I request Dr. C.H. Kiran Kumar Garu to speak a few words.
Good morning, dignitaries on the dais and off the dais. It's an honor for me to be here in Srikakulam in GEMS College and attending this roadmap from bench to bedside of ANA, which we are used to. We in clear in ICUs, we do the ANA testing and we will take the help of all the clinicians and for diagnosing and for the treating the patients. And such a place, especially, I need to appreciate the patrons, Kim's Bullen Bhaskar Garu and all the people for establishing the equipment here, so that we can able to treat the patient in a better way. And I thank each and everyone for giving me this opportunity. Thank you. And special thanks to Nitin Garu also.
Thank you, sir, for a wonderful speech. I would request our esteemed dignitaries to take their respective seats off the dais. A CME of this magnitude is only as strong as the expertise of its faculty. We are truly fortunate to be graced by the presence of our distinguished guests whose work continues to set the benchmark for clinical excellence. As a token of appreciation for their time, their insights, their unwavering support for academic growth, we would like to move on to the felicitation ceremony. Now I request our beloved Dean Ma'am, Dr. Lakshmi Lalita Ma'am, Dr. K. Sudhir Sir, and Dr. K. Nitin Mohan Sir, and Suganeshwari Madam onto the dais for the felicitations.
So I would like to acknowledge the presence of all the stalwarts all over, all the microbiologists, biochemists, and the pathologists all over who have come here. It's wonderful to see you all here at one place. And then I also thank CPC Everlife for really supporting us, and Lakshmi Kantan Garu and his wonderful team being with us and supporting us by all means. And our observer, Dr. Kiran, thank you so much for being here and supporting us. Observers usually observe and go away, but you are different. I'm very happy for what you are. And my senior and our very good friend, Dr. Shiva Kalyani, sorry, Shiva Kalyani, and being here, I'm very happy. And we are expecting few more who are very close to us. So wish you all a very great session over here. Thank you.
I request Dr. C.H. Kiran Kumar Garu, DA APMC Observer of today's CME onto the dais. Please give a round of applause. I request Dr. C.H. Shiva Kalyani, MD, Professor, Department of Microbiology, AMC, Vishakhapatnam. I would like to call upon Dr. Sai Kumar D. Sir, DNB DM Lead Consultant Rheumatologist and Immunologist, Rheuma Care, Vishakhapatnam. I would like to call Dr. Swaminaidu D, DNB DM Consultant Neonatologist, GIMS. I would like to call Mr. Lakshmi Kantan T, Senior Marketing Manager, Everlife CPC Diagnostics. Give a round of applause. Thank you, ma'am. Thank you, everybody. We will now take a short break for refreshments.
So we are short of time, so we are already delayed by half an hour. So please be back by 5 minutes only. Okay, it's an earnest request so that we can start it off, so that you can go back to your places as early as possible. I'm already seeing smiling faces from the because you can go early ante early ఏం లేదు లేట్ గానే వదులుతాను సరే outside.
Welcome back after the break. To begin the scientific deliberations of the day, we have an insightful session on foundations in methodology of ANA testing. This talk will explore key concepts including the debate between IAF, ELISA, multiplex bead arrays in determining the gold standard for ANA detection, understanding the reflex testing algorithm and extractable nuclear antigen panel, the DFS70 revolution, and identifying clinically relevant ANA results. The role of artificial intelligence and digital immunofluorescence in standardizing interpretation. To guide us through this important foundation, it was my privilege to invite Dr. Nitin Mohan sir, professor and head of the Department of Microbiology. May I request Dr. Nitin Mohan sir to kindly deliver the session.
So let's start off the session. Okay. We'll not have a very elaborate one, but still a very important and crucial part that we will be laying the foundation for the further sessions with this session. Okay. So most of what you will be hearing now and the subsequent speakers, the real application part will what be there. Okay. In the next part. So we will be starting off what is with SARDs. SARDs means systemic autoimmune rheumatic diseases. So these are a wide group of entities, okay, and they are associated with a clinical hallmark, or what you can say is a biological hallmark, that is autoantibodies. There is a wide array of autoantibodies that are associated with the following systemic autoimmune diseases, which are very common, means among the common rheumatic diseases, that is the systemic lupus erythematosus, systemic sclerosis, Sjogren's syndrome, mixed connective tissue disorders, and idiopathic inflammatory myopathies. So first and foremost, whenever we start about anti-nuclear antibodies, we talk about the indirect immunofluorescence assay. So first we will be discussing about the indirect immunofluorescence assay. So when indirect immunofluorescence assay was first conceived, what kind of a tissue that was used in the era of 1970s, when what was used was rodent liver and kidney tissue. So because of which what happened was there was a lot of subjectivity, there was very less reproducibility. So what they did, and there was even batch to batch variability. So what they started doing, they started seeing for better alternatives, and the best alternatives that we found out was to be the hep2 cell line. So what is this hep2 cell line? So this hep2 cell line is nothing but the laryngeal epidermoid human carcinoma cell. So why it became an ideal and not the rodent tissue or whatever was there, okay, whatever we was previously using in the 1970s, and now why we are using this hep2 cell? See, when we are talking about what we're talking about today is antibodies against what? Anti-nuclear antibodies. So we will be expecting a cell which will be having a very large nuclei, so that you will be able to see the patterns very easily. So that is what is being provided by this hep2 cell. Then again, there will be patterns that we are looking for. And one of the pattern that we were looking for is the mitotic patterns. So that mitotic patterns can be seen when a cell is having very high mitotic rate. So because it is a cancerous cell, it is having a very high degree of mitosis. Again, this will be like a human canvas. Okay, what we are expecting is maximum number of antigens in a cell, so that all possible antigens we will be able to visualize in a single cell. And hep2 cells are able to provide up to 100 to 150 antigens are present within the same cells. So a very big wide array of antibodies can be detected with the help of this cell. So this became the ideal standard. So the procedure in short, what happens is a slide will be having the hep2 cells, onto which we will be adding the patient serum. And once we are adding the patient serum and incubating it, there will be if the autoantibodies are already present in the serum, they will be going and attached to the antigens that are present within the hep2 cells. Then there will be unbound fraction that has to be removed, and those unbound fractions are removed with the washing step. Still, whichever is what matters is the antigen antibody reaction that will still be there. That has to be recognized, and that will be recognized with the help of a conjugate, and that conjugate is nothing but a secondary antibody, which is usually an anti-IgG antibody, anti-human antibody, which is conjugated with an enzyme. Okay, and that enzyme will catalyze a fluorescent substrate that will be adding later, and that will lead to fluorescence. So this fluorescence is not a direct immunofluorescence, but it's an indirect immunofluorescence. Means what is happening, the fluorescent dye is not directly coming and getting attached to the specific antigens that are present within the Hep2 cell line, but in between what is happening, an autoantibody and a conjugate is being attached. Then only the fluorescence is being generated. So it is an indirect immunofluorescence assay. Now, so how will, after you are adding the conjugate and the reaction, you cannot just see, it would not just fluoresce that you will be able to see it with the naked eye. So what is required is a fluorescent microscope. So this is what is the most important limitations many of the establishments are having, because the very good microscopes, fluorescent microscopes, will cost around 20 to 25 lakhs. So though the running costs are less, the slides are less, the initial investment is huge with respect to having a fluorescent microscope. But as it has become a part of the minimum requirements for NMC for post graduation also, many medical colleges are already having it. So this limitation, we can't say that this is not this is the reason that we are not able to accept it. Okay, now, so this is still, sir, we are talking about indirect immunofluorescence assays, sir. Why we have to start off with this one? So it has a very specific role, and it is still the gold standard. Why it is the gold standard? Because of three main factors. It is having unparalleled sensitivity, and it is having very massive antigen diversity, and what it can provide is a pattern, and pattern is a clinical clue. So one by one we'll be talking about. So the first pillar is unsurpassed sensitivity. Means what is happening, 100 to 150 antigens we are able to detect. Okay, but antigens are already present in the cell, so around 100 to 150 auto antibodies we are able to detect. Okay, we are not able to know which antibody it is. At least with the help of pattern, we know that he is having some kind of a systemic autoimmune rheumatic disease. Okay, so it is having one among the armament that we are having for detection of anti-nuclear antibodies. If you name sensitivity, the other name of that one will be indirect immunofluorescence assay with the help of Hep2 cells. Next is what we are able to get is a cellular pattern. Okay, there are various cellular patterns that we will be able to see, and this cellular pattern, along with the diversity of the antigens, which may be 100 to 150, we are able to get very good clinical clues. So what is most important is these antigens are like native antigens. Means what is really happening in our body, that can be mimicked in case of a Hep2 cell line. Unlike others which are manufactured, we are absorbing onto the solid surface. There are some changes that are happening when the manufacturing process is happening. That is not happening here. So we are it's almost like what is happening in our body, we are visualizing with our naked eye. So we talked about the patterns, why these patterns are important. So not just we are not just giving a number, we are not just saying that whether it is positive or negative, but we are telling some kind of a pattern or inference we are coming, or interpretation that is given. That is what is important for the clinician to go for the next level of testing. So which kind of test he wants to do, if he wants to go to hit a specific molecule he wants to hit, so the pattern is going to give them a hint. So that is the main importance of having indirect immunofluorescence assay, especially Hep2 based. Now these are all the patterns that are usually seen. Okay, where these are the common patterns that are usually seen. They are the homogeneous pattern, they are the speckled pattern, they are the nucleolar pattern, and there is also centromere pattern. The homogeneous pattern is usually the smooth pattern that is associated with SLE. The speckled pattern is usually dotted, and it is also nuclear, and it is usually seen with the extractable nuclear antigens. And nuclear patterns, you will be able to see them as bright dots. Okay, and it is associated with systemic sclerosis. And you will be, if it is a centromere pattern, you will be able to see discrete uniform speckles, especially when there is mitosis. Now, so the question just for all of us to think is, We are talking about and autoantibodies as anti-nuclear antibodies. We are having the cytoplasmic patterns also, isn't it? Yes or no? We're talking about cytoplasmic patterns also. It's still anti-nuclear antibody. The apt name for these autoantibodies, I would say it is debatable. Okay, there may be in future guidelines may be coming and there may be a new name, because cytoplasmic patterns are also associated with rheumatic diseases. Okay, so in it, these mitotic patterns are usually also seen in the cytoplasmic part only. Not every pattern that we are seeing in the indirect immunofluorescence is always nuclear or nucleolar. So there is cytoplasmic patterns and mitotic patterns which are beyond the nucleus. So I think this name doesn't justify the name as it is now, that is the anti-nuclear antibody. So what was happening was, uh, I in Srikakulam will give one name, okay, to that pattern. Kalyani madam in Visakhapatnam will give one pattern, okay, but we will be seeing the same slide. Okay, there is a difference in standardization. So I will give one pattern, Chandrasekhar will give one pattern. Within the laboratory also there may be the variation. So in order to means break this chain of variation or confusion, what was happening means different locations were giving different patterns as a dictum or local dictum. So there was a solution that came up, that is what is called as the ICAP pattern, that is International Consensus on ANA Patterns. So how many patterns are there? There are around 29 patterns are there. And these patterns constitute the nuclear patterns, the cytoplasmic patterns, and the mitotic patterns. So the zone 1 is the nuclear pattern, the zone 2 is the cytoplasmic pattern, and zone 3 is the mitotic pattern. So if you are seeing, for example, in the slide, if you have seen the nuclear pattern, you have to assign one of the number from 1 to 14. So that is how we usually go about giving it. So what happens is, in the report, once you are testing for ANA antibodies, so you have to tell which process you are going for, and if you are process in which you have mentioned it as indirect immunofluorescence assay, then you have to not only mention what is the pattern, you have to give the number. That is what which is ICAP associate. So even if the person shows this report in United States of America also, where they themselves have generated this consensus statement, he will not see for what is the what I have given in the report. He will just see the number, and he knows that this is the pattern they have seen and I am also seeing it. Okay, so that kind of consensus we can come about with this kind of ICAP nomenclature. So now, so what happens is, there is a kind of subjectivity, okay, that may happen. So if some measure of this subjectivity can be reduced with the help of computer-aided immunofluorescence microscopy. The best examples in the market are the Euro pattern or the NOVA digitization slide digitization methods. Okay, so some kind of automation you can use for this computer-aided microscopy you can use. So this is already helpful in reducing some amount of digitization. So this can be when you add further algorithms, okay, machine learning algorithms and artificial intelligence. So what kind of automation which we think about the laboratories? So microscopy can also be automated with these technologies. So we in details will be talking about in the subsequent slides. So what is the greatest limitation of anti-nuclear antibody testing? So we talked about its being a very sensitive test, very sensitive test. But what happens is, we are doing a trade-off with the specificity. We're doing a trade-off with the specificity. What is happening here is, we are able to see some anti-nuclear antibodies even in normal individuals, because it is so sensitive. So there are false positives. So the trade-off happened with the specificity. Now, so the key core takeaways for this indirect immunofluorescence assay. So the substrate is standardized worldwide, that is to be HEP2, and the output we are getting a pattern that is clinically relevant and will guide further testing. And what happens is, in spite of so many limitations, you can say it is still the gold standard. So the answers will be in the subsequent slide why it's still the gold standard. So from slide, we are going off to the solid phase. So the solid phase where we will be absorbing the antigens and looking for the antibodies. And the techniques we will be talking about is enzyme-linked immunosorbent assay and the multiplexing of these ELISAs, that is the enzyme immunoassays, that is multiplex immunoassays. So previously, what happens when we were doing this manual testing, there was limit with the volume of the patient sample that we are getting. So if you want to test for 10 to 20 anti-nuclear antibodies, how much of blood we need to draw? Okay, again there will be a labor associated with testing, repetitively testing for individual of one of the anti-nuclear antibody. And when you're performing so many antibodies, there may be human error that may lead to further confusion, coming to a conclusive diagnosis. So there will be always an information deficit for all of us, because of which many laboratories which are having very high sample load, they are always attracted towards the automated systems. So first, these automated systems are basically based on the enzyme-linked immunosorbent assays, or they may be linked on the multiplex immunoassays. So first we'll be talking about the enzyme-linked immunosorbent assay. Very simple. The solid phase is being already adsorbed with an antigen, or that is the autoantigen. So if the serum is added, the autoantibody is going to get, patient serum is added, the autoantibody is going to attach to the antigen that has been adsorbed onto the solid surface. Then in order to detect this antigen antibody reaction, again you have to add a conjugate, and this conjugate is an anti-antibody, anti-human antibody, which is conjugate, which is having an enzyme or attached enzyme, and that enzyme will act either on a colorimetric substance or a fluorescent substance in order to give the signal that the antigen antibody reaction has happened. So this LSA has been automated, and this automation, how this automation helps us out because of the precision pipetting volumes. So manually the pipetting volumes may little vary. So the pipetting has been standardized. Incubation times, okay, they are exact when there is automation. So samples are rigorously washed. Okay, so when you are washing, the background noise gets reduced, and you are able to have an automated spectrometric reading, because of which you are able to quantitate the amount of anti-nuclear antibody that is present. So, but what happens with LSA is, one LSA can detect one auto antibody only. So what I'm not satisfied with that, neither were many of the people. Okay, as laboratory diagnostics personnel from the laboratory field, we never get if you have to perform many tests, we are never happy, isn't it? So what we have to do is, we try to multiplex the same well, and in order to try to multiplex the same well, what we did was, I cannot use number of so what I did was, I had to increase the number of solid surfaces, and that I did was by using the beads. Okay, and by using the beads and putting these beads in a liquid suspension, I was able to multiplex the same surface. So what happened is, what LSI used to do for a single molecule or a single antigen, this multiplex immunoassays were able to do it for multiple antigens or autoantigens. Okay, so we will be able to at a time within a single reaction vessel, we will be able to discover many number of autoantibody, at least 10 to 17. So what happened is, on a plane I was absorbing the autoantigens in ELISA. Now I have suspended it in a liquid suspension, and in order to detect them, I'm using the flow cytometry principle. Okay. Now, so what happened with this multiplex bead immunofluorescence assay is, each bead has its own unique signature. Okay, that why each one had its own color. Okay, and they were coated with individual or specific antigen, so they developed its own color. Okay, and all of these were in a reaction mixture that was in a liquid phase. So what happens is, so I have to detect two colors or two dyes or two fluorescents. Okay, if I'm talking about color, I'm using a generic term, that is color. It can be colorimetric or it might be fluorescent. So I have to detect two colors. So in order to detect two colors or two fluorescents, what I have to do is, I have to use two lasers. One laser to detect which bead that is, and another laser to detect the coated antibody after the reaction has happened. So this is done with the help of the classification laser, which is red, and the reporter laser, that is green, because of which this dual laser interrogation, we are able to quantify multiple number of autoantibodies within the same well. Okay, so instead of well, within the same reaction vessel, we are using beads, which are either magnetic beads or we are using polystyrene. So the same polystyrene that is being used for LSA in order to prepare the wells, they are also being used for the preparation of the beads also. So this is the what we can talk. So LSA was a solid phase, and multiplex immunoassay are happening within the liquid suspension. So the multiplexing capacity, which was not associated with LSA, was possible because In liquid suspension, there are beads which are absorbing many number of antigens. So what is the major difference is LSR required large or huge amount of sample volumes from the patient. Now multiplex immunoassays are able to do array of antibody testing with microliter volumes of patient serum. That is what is very very important. Sir, ఇందులో ఏముంది సార్ అని అనుకుంటే పేషెంట్కి రెండోసారి నాకు శాంపుల్ కావాలని ఒక్కసారి అడిగి చూడండి. టెక్నీషియన్స్ అడుగుతారు కాబట్టి మీకు ఆ బాధ తెలియదు. మీరు ఒక్కసారి అడిగి చూడండి, మరొక శాంపుల్ అడగండి, ఇది బాగాలేదు అనుకొని అప్పుడు ఆ లిమిటేషన్ ఎంత పెద్ద లిమిటేషన్. కన్సల్టెంట్ విఐపి పేషెంట్, విఐపి కన్సల్టెంట్ పేషెంట్ అనుకోండి, ఫోన్ కూడా మీకు వస్తుంది, ఏంటంటే రెండోసారి పేషెంట్కి శాంపుల్ అడుగుతున్నారు అని అంటారు. సో దట్ ఈస్ వై వీఆర్ ఆల్ వరీడ్ అబౌట్ మల్టీప్లెక్సింగ్. ఓకే, now so what I can say is, so because we are detecting a single we are coating a single antigen onto the solid surface, either onto the bead or onto the well, what happens is the reaction is very specific to detection of the specific autoantibody. So if the other name of sensitivity was indirect immunofluorescence assay, the other name for specificity, if you can say, in autoantibody testing is the solid phase assays, which is either LSR or the multiplex immunoassays. So what happens is, we are talking about indirect immunofluorescence assay. We are able to detect a very high variety of the anti-nuclear antibodies. But when you are coming to the solid phase assays, which are usually automated, we are narrowing ourselves down to the specific antibodies. Okay, so as much, so 100 to 150 becomes now 10 to 17. Okay, so 10 times reduced. Now, so what is happening? This is a very lopsided algorithm. That is what we usually face. What happens is, ideal algorithm at the end of my session, but what happens is automated system తెచ్చాం, ఎవరో చెప్పారు బాగుంది, ఓకే, డిమాండ్ కూడా బాగుంది మనకి, ఓకే, మంచి శాంపిల్స్ కూడా వస్తున్నాయి. సో ఆటోమేటెడ్ సిస్టమ్ తెచ్చాం. ఆటోమేటెడ్ సిస్టమ్ తెచ్చినప్పుడు క్లినిషియన్ is suspecting highly that he is having a systemic autoimmune rheumatic disease. But what is happening? It turns out to be negative. Why? We are specifically looking for the 10 to 17 antibodies only, but we have left, when you minus this 10 to 17 from 100 to 150, there is a 10-fold difference. What is happening? If they are having some kind of autoimmune disease which maybe not be usual and rare, we still are missing. That is the reason. So what happens when there is a comparison with the comparison of these results? Okay, when we have given negative, our lab is going to get a we are not false, our run was there. So which antigens we tested or which antibodies we tested, those are negative. We are not beyond that limited menu, beyond that menu we are not having. So that is the reason. So if the clinician still tests, if the clinician still very much suspects it, you can retrospectively go for indirect immunofluorescence assay in order to support yourself at least. In order to support yourself at least. So now, so the solid phase has been removed, and instead of the solid phase, what is there is an electrode. Okay, sometimes it's a carbon electrode, and a carbon electrode onto which you have adsorbed an antigen. And then what is the conjugate here? Sulfur tag. Okay, so once you are passing the electricity to the carbon solid surface, what happens is there will be a if the antigen antibody reaction has happened, okay, there will be continuous transmission to the sulfur tag, and the sulfur tag will be able to release the chemiluminescence. So this is the technique behind the electrochemiluminescence. So most of the studies are why I kept it as not as a solid phase assay, or I'm not including it in the algorithm, because I have not come across many of the studies that are based on electrochemiluminescence assay. Not most of the ACR or the EULIR guidelines are referring mostly about the multiplex immunoassays or LSRs only in comparison to indirect immunofluorescence assay, and there is not much literature on ECL, but still I wanted to let you know the principle behind it. So again, this is the trade-off that we are doing, the wide net for the immunofluorescence assay and the target net for the solid immunoassays. So what is happening? A peak sensitivity test we are having. One is at provides us peak sensitivity, and other is providing us the peak specificity. So this is what happens when there is peak sensitivity. So indirect immunofluorescence assay if some of us get tested, I will say today it is free testing, so you get tested. So at least 10 out of 10 10 of you, the delegates, 3 delegates are going to have some or the other autoantibody in their indirect immunofluorescence test positive assay. Okay, so healthy individuals still have autoantibodies when they are tested by indirect immunofluorescence assay. So that is the vulnerability of indirect immunofluorescence assay, because it is very, very sensitive. This depends upon the dilution that you are using. And if you use a very low dilution of 1:40, in healthy individuals, the more the chances of the test turning out to be positive for some or the other pattern. Okay. Now, the solid phase, what happens is it is having 10 to 17 antigens only. So it is able to detect those many antibodies only. So what happens beyond that, if he is having any other disease, any other autoimmune disease, which cannot be detected by this panel, those are being missed by this solid phase immunoassay. So this specific disease wise, how this principle or what are these limitations are getting applied. So once you are coming to systemic lupus erythematosus, which of these tests is best? So indirect immunofluorescence assay is the best, because it is having 90 to 95% detection rates. But once you come to solid phase performance, it is going to be less, because anti-dsDNA and anti-SM are not easily detected with the help of indirect immunofluorescence assay. So in our hospital settings, where we have lots of amounts of dialysis, and that too it is associated with lupus nephritis, so the demand for indirect immunofluorescence assay in our setting is less. So we have started with ANA profiles first. Okay, so that is the justification, because of which, see, everything is economics. Okay, and we are fulfilling the needs of the clinician, and we are fulfilling the economics of the hospital, running the hospital also. Okay, now coming to this is completely if these would have been the cases, my method of doing autoimmune diagnostics within the Great Eastern Medical School, it completely failed. If it is Sjogren's syndrome or inflammatory myopathies, because these HEP2 cells will miss specific autoantibodies driving this condition, that is the anti-Ro52 or SSA or anti-Jo1 myositis, and these can be specifically detected with the help of the solid phase assays. Okay, so the clinician should know which test according to which condition is best. Okay, again, coming to systemic sclerosis, the performance of indirect immunofluorescence assay is very good. 100% of the cases can be detected, but that's not the case with the enzyme immunoassays, because false negatives are there for the SSC. Okay, so SSC is nothing but the RNA polymerase 3. That is these solid phase or the enzyme immunoassays are not able to detect. So systemic lupus erythematosus, so which indirect immunofluorescence is best. Sjogren's syndrome and in idiopathic inflammatory myopathies, again the solid phase immunoassays are best. Systemic sclerosis, again we come back to indirect immunofluorescence. So there is always a tension between the sensitivity and specificity. There is always a tension between the indirect immunofluorescence assay and the solid phase assay. So if both of the tests come negative, then the person is not going to have, you can straight away declare or pass your judgment that no, he is not having any kind of systemic autoimmune rheumatic disease. But if both are positive, definitely is having some or the other systemic autoimmune rheumatic disease. Okay, now, so there are limitations of this test that we are worried about. So what is happening here is we are always looking for the perfect test. So tell me one test that will be diagnosing it. Okay, one test that is diagnosed. We don't know the clinical picture, but we are asked to know. We are to tell, sir, suggest one test. This is happening. So perfect test is always a trade-off. So we are now trading off between three modalities, that is indirect immunofluorescence assay, the LSA, and the multiplex immunoassay. So why we will be talking first about the limitations regarding indirect immunofluorescence assay. So one biggest bottleneck is the human interpretation. Okay, and in addition, there is substrate variability based on the manufacturer. So two manufacturers are already there, Euroimmune and the MedSource Ozone. Okay, there is already a dishum within our market already. Okay, so our elegance changes with our knowledge as when it is increasing. So if you want to start it off, you start with what is accessible, but once you have known the ins and outs, you look for the best. Okay, so next is the reagent inconsistency between the kits, and there is always uh, government medical college in Andhra Medical College will be having one fluorescent microscope model, and RIMS Srikakulam will be having one fluorescent model. They will be using the same kit, but the fluorescence will be different. Okay, that is the hardware difference. Now, so what is happening here is we are trying to fix the Hep2 cells onto the slide. We are trying to fix the Hep2 cells onto the slides. So this fixation process of the Hep2 cells on the slides leads to destruction of some of the autoantigens. And this destruction of some of the autoantigens will lead to blind spot in indirect immunofluorescence assay. So what is happening is negative tests may happen in spite of presence of autoantibodies by indirect immunofluorescence assay, especially for low abundance antigens. Especially for low abundance antigens. Now, this is what we are all worried about, that is the prozone effect or the hook effect. So what is happening? Optimal antigen antibody concentration and lattice hypothesis is known to all of you. Okay, the same applies here also. So what happens when there is antibody excess? What is happening here is the antibodies will be completely covering the antigen coated onto the solid surface, not allowing the conjugate to get attached, because of which it is false negative. Because of which it is false negative. So you have to use appropriate dilution. There is a debate on it later on also. Okay, so next, after the discussing about indirect immunofluorescence limitations, now we are talking about LSR limitations. So what is happening? So the sensitivity net of indirect immunofluorescence was very huge. Now when compared to LSR, we are detecting single molecule. We are detecting single molecule, or there may be a cocktail of auto antibodies that can be detected, because of which what happens, if you are directly using ELISA as a first test, there will be again false negative. Now, so what happens is, in multiplexing of the immune assays, many a times we will be manufacturing these proteins which will be coating onto the beads or the solid surface. So what happens is the 3D structure of, so these antigens that we are coating are nothing but the proteins, and they are having a 3D structure, and that 3D structure is going to be lost. And because of the loss of this 3D structure, the B cell recognition is being lost. So this is going to affect the assay performance, especially in case of enzyme immunoassays. Again, what happens is the antibody concentration and the adsorbance, and the adsorbance. So more the antibodies, more the adsorbance will be there. But what happens, this linear relationship is for a limited adsorbance. Okay, this equation can no more hold true when the serum is saturated with excess amount of antibodies. So we have to work out the dilution. So we have to do a dilution before we are performing the solid phase immunoassays. Now, so you are able to see a multiplex immunoassay panel where we are only detecting 3 autoantibodies. Okay, but another panel is there. They are claiming for 30 or detection of 30 autoantibodies. So more will be the autoantibodies they are claiming to detect. More will be the cross reactivity. More will be the cross reactivity. So cross reactivity is a issue with multiplexing. Again, with multiplexing, what will be the problem is heterophile antibody. The heterophile antibody is going to cause false positive signal and also false negative. How it is going to cause a false positive signal? Because this heterophile antibody is going to act as a bridge between the antigen that is present on the surface and to the conjugate, because of which there will be a false positive signal. And what happens when there is false negative means, what is happening, the antigens that are present on the capture bead will be coated by the heterophile antibody, and hence all of the spaces will be occupied, and there will be no place for the real autoantibody that is present in the serum to come and get attached, because of which there will be a blocking effect and there will be false negative. Okay, now, so whenever there is treatment, that the patient has been diagnosed as autoimmune disease, okay, and then he has undergone treatment, indirect immunofluorescence test may come positive, but the multiplex immunoassay will come negative, giving a false sense of cure rates. Okay, that is what is the problem with multiplex immunoassays. Okay, now when we're looking for detecting multiple analytes within the same reaction mixture, we have to put, ideally we have to check for each, and we have need to have a QC for each analyte. And this becomes problem when you are trying to do it in a single reaction mixture. So we have to find for an ideal QC analyte. That ideal QC analyte is no, not at all possible. Okay, what may happen is your QC programs, especially for multiplex panels, are very, very costly and cumbersome. Okay, so the problem with indirect immunofluorescence assay is the prozone effect. Okay, the problem with solid phase ELISA, what is happening is restricted antigens, and in case of multiplexing, what is the problem is especially the heterophile antibody and the problem of calibration. Okay, now what is happening here is, once a test comes positive, for example, indirect immunofluorescence assay is positive, okay, the clinician always expect that the person is having systemic autoimmune rheumatic disease, but it may be it's still an misconception, because what happens is 20 to 30% of normal individuals are harboring auto anti-nuclear antibodies. So you cannot say that whenever there is an indirect immunofluorescence assay positive, directly don't label them as he is having systemic autoimmune rheumatic disease. The reasons are these, why there is a benign this positivity is called as benign immune response, and the reasons are age related because of loss of B cell tolerance, or there may be hormonal factors, especially estrogenic, and there will be environmental exposure, especially because of xenobiotics, silica, infectious agents. So these are the reasons for the presence, the 30% individuals showing for positive for indirect immunofluorescence assay. So I could not come across Indian studies, but I came across a study that has been done in US by National Health and Nutrition Examination Survey, where they started to map the demographics of healthy individuals who are positive for anti-nuclear antibodies, and they saw that the female to male ratio, means females are more getting affected, especially in the age groups of 40 to 49. Again, the non-Hispanic African Americans had more chances of healthy individuals having anti-nuclear antibodies, and youth especially. When we started seeing the demographics, previously healthy individuals, healthy teenagers having anti-nuclear antibodies was 10%, it has increased to 30% now. So still, because of the hypersensitivity, so this may be one of the reasons we are overdiagnosing in healthy individuals the ANA disease, you can say, or autoimmune disease. Now, this is what is most important, and that advantage we are taking care of in our setup, because we are having an ANA profile 3, which is able to differentiate from the DFS 70. So DFS 70 antigen, DFS70 antigen is present more in healthy individuals than in normal individuals. So if you are including this into a panel, and you want to know whether he is having non-specific anti-nuclear antibodies, or he is having specific, you want to rule out, and if he is positive for DFS70, then he is no more having autoimmune disease. Okay, so this molecule is already in our panel, and we expect most of the testing to include this panel, so it is easier for the clinician to differentiate. So what is DFS stands for? It is dense fine speckle 70. Okay, so it is having a decoy effect. Now, so if you want to cut off this noise, you have to go for the best dilution of the serum. So when you are seeing for 1:40 titer, there will be more number of 30% of normal individuals will be having ANA. So once you increase it to 1:160 titer, it reduces to 5%. So you may all theoretically think it's best because 5% is the positivity rate, but it's best to have 1:80, which is midline of what is 140 and 1:160. Okay, So it will take care of the weak transient autoantibodies while retaining the core sensitivity when it is 1 is to 80 titer. Okay, so you are able to see a traditional immunofluorescence assay, which is a crowded room, and you are able to see the solid immunophase assay as a our auditorium. Okay, so we are having less number of autoantigens here. Okay, so what is happening here is you have to maintain a balance. So that balance can be maintained when you are having an algorithmic testing. And even if you say that, sir, this is a problem with IIF only, so why not only directly use the solid phase immunoassays? If you are doing the solid phase immunoassays only also, there will be 7.4% of the individuals still getting positive results with solid immunophase assays, even if they being very high specific. So why this happens? Because when you are coating the antigens, when you're coating the antigens onto the surface solid phase, there will no more be native. Okay, there may be changes in the antigens that may be happening. So autoantibodies are not able to bind to them very well. But what is most important, what is the reasons for false negatives? Because beyond the 10 to 17 other autoantibodies were not able to detect. Okay, now, so again, which kind of ELISA you are using for detecting of these antibodies or autoantibodies also matters. If the ELISA is having the extracts from Hep2, then it will be very sensitive, just like indirect immunofluorescence assay. But if you are using an ELISA which is using purified antigen mixtures, you will be getting the sensitivity and specificity as good as the multiplex immunoassays. So what happens with the indirect immunofluorescence assay is, again, the positivity in healthy individuals. So some may say it is okay, it's not at all okay, it's a pattern that is not clinically significant. Another individual who will interpreting the pattern, he may say that it is significant. So interlaboratory variability is one of the factors also. Okay, so in order to maximize the accuracy, what we need to do, we have to do an initial screening with Hep2. If it is negative, consider it as negative. Okay, no follow-up is needed. But if you are going for if the Hep2 IIF is positive, you have to go for the confirmatory testing, which is multiplexing or solid phase assays. Okay, so this is what we propose. Okay, initial screening with IIF, positive classical ANA pattern. Okay, there is you can go for the confirmatory test. If it is negative, no follow-up is required. But if the DFS 70 pattern, okay, we have added it, DFS 70 pattern is suspected, the what happened is you can go for a specific ELISA, or you can use such an test where DFS 70 is being recognized as an independent parameter. Okay, that is what is possible because of the line immunoassay that we are using, which has DFS 70 band, and we are able to exclude it. So it will be able to resolve whether it is a non-specific increase in autoantibodies, or it is really associated with autoimmune diseases. The recent advances are, you are trying to remove the DFS 70 with the help of a biochemical reaction and then perform the indirect immunofluorescence assay. Further recent advances have appeared with the help of computer-aided diagnostics along with algorithms of artificial intelligence. So we have able to even automate the indirect immunofluorescence assay. So this is the what happens, the workflow with the when you are introducing automation. So we are able to achieve the same diagnostic accuracy. And what happens is, because we are including this automation, the laboratory capacity to perform more number of samples. Okay, you will attain the capacity to perform more number of samples. So my concluding remarks, so there is a biological reactivity that we have to all accept, that the autoantibodies are very diverse. Okay, and we are balancing between sensitivity and specificity, and we have to also balance our workflows that are happening within the laboratories. So this is there is always a trademark trade-off happening within this trademark triangle. Okay, so what happens is we have to accept the fact is 30% of the individuals, normal individuals, are going to have auto antibodies. Okay, and there is a decoy, that is DFS 70, that has to be ruled out, and we have to optimize the assays with respect to specificity. Okay, uh, so if you want to know what is happening within the body, as nearer to the body, that is what is best personified by indirect immunofluorescence assay, and it is still the gold standard. So as it is the gold standard, which has been declared by ACR, that is American College of Rheumatology, and the EULAR, that is the European guidelines, they say that any kind of automation or new test that you are also going to introduce within your laboratories, that has to be as good as indirect immunofluorescence assay, or in fact better than indirect immunofluorescence assay. So you cannot just sidestep the indirect immunofluorescence assay. In spite of utilization of CAD, that is computer assisted diagnostics, or artificial intelligence, there is always a man behind that loop, and they are as good as the man behind that loop. You cannot remove the man behind the loop. So the microbiologist or the pathologist or the biochemist, they have to be behind it in order to say that okay, you have the paper becomes a report only after you are going to sign it, or it's just a figure, and it will never be a report that a clinician can rely on. Okay, so indirect immunofluorescence, there is high throughput assay, high throughput can be done now. So DFS 70 pathogenic patterns have to be differentiated, but the IIF fails when there is anti-Rho and anti-Jo. ELISA fails, okay, when there is low titer or when there is early disease. Multiplex immunoassay fails in case of treated patients, and there is cross reactivity when there is more number of multiplexing. So these are all the references that I have used, and best references, okay, I have highlighted almost 72 references I have used in order to prepare this. So this concludes my presentation, and if I have rushed through many of the things because we are shortage of time. Thank you for patience.
Thank you, sir, for providing such great insights on the topic. We now move from laboratory methodologies to clinical applications. This session focuses on the clinical relevance of ANA testing and addresses important questions such as what is the biology of autoimmunity and why do we produce ANA? Why should clinicians order an ANA test? Understanding cytoplasmic and mitotic patterns in ANA interpretation. Why reporting ANA simply as positive or negative can sometimes be misleading. To deliver this insightful talk, we have with us Dr. Sai Kumar D, a very renowned rheumatologist and clinical immunologist, bringing valuable expertise in autoimmune diseases. Please give a big round of applause. Dr. D. Sai Kumar is a distinguished lead consultant rheumatologist at Trauma Care Vishakhapatnam with a career defined by clinical excellence and robust academic foundation. He specializes in the management of complex autoimmune conditions, including inflammatory myositis, systemic lupus erythematosus, and connective tissue diseases. Dr. Kumar's academic journey is marked by high distinction, beginning his MBBS from Allur Sitaramaraju Academy of Medical Sciences, where he has named the best outgoing student. He completed his DNB in General Medicine at Christian Fellowship Hospital, Odanchatram, followed by a highly specialized DM in clinical immunology and rheumatology from the prestigious Jipmar Pondicherry. His international credentials include the MRCP Specialty Certificate in the Rheumatology. A dedicated researcher, Dr. Kumar has contributed significantly to the field of rheumatology through his work on disease outcome measures and biomarkers. His research has been recognized globally, leading to oral and poster presentations at major international conferences such as ACR, EULAR, KCR South Korea. He is also a recipient of international scholarship for young rheumatologists from the Korean College of Rheumatology and a research grant from the Indian Rheumatology Association. Beyond his clinical and research roles, Dr. Kumar has demonstrated leadership as a member of the COVID 19 vaccine task force for the Indian Rheumatology Association. He is an active member of the Indian Medical Association and the Indian Rheumatology Association, committed to advancing rheumatological care through both traditional practice and modern tele-rheumatology solutions. May I invite Dr. Kumar sir to kindly deliver this talk with a round of applause.
Thank you for the introduction. Still good morning. Still it's 11:35. So after I heard Nitin sir's lecture, so I got my vivid dreams back because when we do immunology in Zipmer, we have to have this fluorescence, green value, wavelengths, everything on our fingertips because we don't know whenever they ask us. Suddenly, whenever a patient carries a report in ward, they'll just ask me what is the laser, what is the technique, what is the methodology they have used, why this is used, why this is not used. So you have to tell everything. So my vivid dreams came back again. So good afternoon, good morning still. I'll go through the ANA, clinical correlations in choosing wisely. The outline of presentation will be the biology of autoimmunity. Why do we produce ANAs? And then when to order an ANA, avoiding a shotgun approach. And cytoplasmic and mitotic patterns, which Sir has touched upon, and why the ANA is N in ANA is misleading. So that's why ICAP has renamed it as AC patterns, not AN patterns. These are all anti-cellular patterns. You have 1 to 29. So they have renamed them as ACs, anti-cellulars. So you have a loyal person in your body who protects us from all the infections, virus, bacteria, whatever it is there. It was loyal to us all throughout our age. When you are in childhood, you played in sand, you played everywhere. You ate whatever was available on the ground. You didn't have any infection or autoimmune disease at that time. But subsequently, after you attain some age, you are prone for autoimmune diseases. So what is the killer switch and why our loyal servant is going to kill us? So we'll go through like Durandar type presentation with each chapters. Okay, chapter 1. So you have a perfect system in your place, which is peaceful, a kingdom, which is there. You have an innate immune system, you have an adaptive immune system, which is there. And these attack or kill the pathogens or viruses which are coming, which are attacking us. So then you have an infection, but still after the infection comes, your immunity got triggered. Do you know why after the infection, after some time, your fever will decrease, your ESR and CRP decreases? Because you have tolerance mechanisms in place, which will check the immune system, which will not allow it to go into a hyperimmune phase. So this is the place where if you have heard a dengue hepatopathy, which is a macrophage activation syndrome, which is happening in the patients who have defective NK cell function, these patients will go on having a persistent inflammatory hyperimmune response. Because of that, they go on to have a macrophage activation syndrome, which is commonly known as a dengue hepatopathy. Or that's why in dengue hepatopathy, you give steroids. In any other this thing, you don't give steroids. So the basic rule of this is never attack your own. This is the basic rule what a perfect immune system follows. But what happens is there is an escape. So each time in a medical college or in anything, you have one black sheep or one person who is problematic, because of which we all go for punishment. We have gone through all of this. So this happens, or this is kept in check by a mechanism called central tolerance, which happens in the bone marrow for B cells, which happens for T cells in the thymus. So what happens here is there is a failure of central tolerance. Some cells survive the check mechanisms. So whenever a B cell is screened for the affinity to self, these cells will get eliminated by killing. They'll go into energy or apoptosis, or they'll not be given a survival signal. If they survive, they be left over as an autoreactive B cells. So that's why you have some patients having an autoantibody without any disease. So these are the autoreactive B cells which are there, which are circulating, but these will not cause autoimmune diseases unless they need help with a T cell. When you have help with a T cell, these autoreactive B cells will go on to have an autoimmune disease. So, and there are some tolerance mechanisms which are in place. This prevents an autoimmune disease to develop whenever you have a autoreactive B cells. So next, the crime scene. What is the crime scene? Daily we are having a crime scene happening in our body. That is an apoptosis. So daily some cells are undergoing death. So, but this apoptosis is a well-controlled pathway where your antigens are not exposed to outside. It can be your nuclear material, it can be your cytoplasmic material. Nothing is exposed whenever an apoptosis happens systematically. But in patients who are predisposed to an autoimmune diseases, like they have a genetic susceptibility, what happens is their DNA is exposed. So they'll have the nuclear proteins exposed. So because of this already we know that there are autoreactive cells which are circulating, and these cells detect these exposed antigens and they start producing antibodies. So you have debris which is persisting, you have immune exposure, and the autoimmunity is triggered. So next, what happens is ideally your apoptosis has to be clean. Have you ever heard of C1q? So there is a one complement called C1q, or which is there on the apoptosome, which will help in engulfation of these apoptosome by a macrophage. This is a clean process which happens. Whenever a patient is deficient with C1q, they'll go on to have a juvenile SLE, because this apoptotic debris will not be cleared, and in their early age itself their apoptotic debris is exposed to our immune system and they go on to have an autoimmune disease. So they'll have failure in clearance mechanism, debris accumulates, and the clearance mechanism timing window is missed, and then the autoimmunity is triggered. So this is what the final thing is. So what our body will think, why the DNA is outside? Is it an infection? Because body doesn't know it, whether it is an infection or the self, because it only detects the MHC. It doesn't detect any other particles which are inside the cells. Intracellular contents which are released into the circulation is considered as a foreign. So is this infection? This looks foreign. So it starts attacking. Owing to this, you have a twist. This is called nets. So neutrophil extracellular traps. This is like a fisherman throwing a net into the lake. So you have a neutrophil which is activated, which will throw a trap. This is called neutrophil extracellular trap, where the neutrophil extrudes its genetic material, chromatin, with antigens like elastase, lactoferrase. These are all enzymes which are there, which are secreted, or which stick onto this chromatin material, and these engulf the bacteria and then clear the infection. This happens normally, but in a genetically predisposed individual, whenever already this has happened and this process is foreign, and then it will start secreting a neutrophil extracellular trap with our exposed with which unexposed DNA into outside. Our immune system starts detecting this also, because they're genetically predisposed, and then they'll start producing antibodies. So and then they'll go on to have an autoimmune disease. So this neutrophil extracellular trap has been shown to be pathogenic more in case of ANCA vasculitis. So ANCA vasculitis, in the name suggests, it is an anti neutrophilic cytoplasmic vasculitis, because the cytoplasmic contents of the neutrophils are detected as antibodies. The predominantly the nets will have the cytoplasmic antigens adhere to that nets. So then the false alarm has triggered, because there is a DNA which is circulating, there is an RNA which is circulating in the blood. There are some TLRs, toll-like receptors like 7 and 9, which are the pattern recognition receptors, which will signal the immune system that something foreign is happening, and then it will start stimulating the antigen presenting cells, and then the autoimmunity triggers. So it will consider the self-nucleic acids as the pathogens, and it will start producing cytokines, which are predominantly interferons, TNFs, other cytokines. If interferon is elevated, the disease what we see is commonly is SLE. If TNF, it is predominantly spondyloarthritis or the rheumatoid arthritis. Depending upon the which arm of the immune system is stimulated more or which cytokine is stimulated, you classify these diseases. So which cytokine gets stimulated, which pathway gets stimulated, it again filters to your basic genetics again. So I said there are some autoreactive rebels which are sitting there. So whenever this nucleic acid has come up, this B cell gets awakened because the antigen presenting cells got stimulated. Then the T cells came, and the B cells will get educated with these antigens, and it will get converted into plasma cells and then start producing your autoantibodies. You have ANA, anti-dsDNA, several autoantibodies which are produced. So this factory is started. So whenever once the factory of plasma cell has started, your ANAs never go away. So have you seen any patient who has been treated, his ANA go away? No. Their disease may go into remission, but ANA will stay, except they go into CKD or high proteinuric states, and unless they have received any B cell suppressive therapies like daratumab, and you remove plasma cells, in that cases their antibodies will go away. So this is a circle which starts. Plasma cell starts producing antibodies, and then you have several antibodies which are there circulating in the blood, and then you have the diseases. You have ANA, ANCAs, anti-dsDNAs, anti-SM with different sensitivity and specificity. Depending upon the antibody sensitivity and specificity, you have different organ manifestations. So this is a perpetual loop in which the patient gets stuck. So because you have antigen presentation, you have continuous factory production of antibodies. These antibodies are still destroying the organs, and then again the self antigens are released from the damaged cells, and then you have a perpetual vicious cycle which is going, and then you have a persistent antibody production. So this is a summary. You have failure of tolerance mechanisms, apoptotic or net-derived antigens, autoreactive B cell activation, loss of B cell tolerance, and you have chronic immune activation in an anti-nuclear antibody. So you should suppose that we are also having the same mechanism. So you should suppose that every time we are also going through this mechanism, right? But we are not having an autoimmune disease. For example, in the same twins, if there are two twins, one will have an autoantibody, like they are diagnosed with SLE, and other will not have a disease at all, even if they are monozygotic twins. This all depends upon the external environmental trigger or the genetic susceptibility or the genes or the amount of copy variations what they inherit. Depending on that, one person is going into an autoimmune disease and another person is not exposed to will not develop any autoimmune disease. So finally, it's like, if you see, you have Sivagami, like, who is protecting our immune system, like with tolerance. You have Balaldeva. If you see in that fight, he tries to kill his own people. So, but still Sivagami gives to Bahubali because he's a tolerant, and then he's the tolerant gun who protects our immune system. But Balaldeva has inherited his genes from whom? Vijal Deva, who is cunning, correct? So he has a genetic predisposition of being like harmful to us, correct? So then you have an external factor, infection. So Anushka, who came into the picture and then confused the whole immune system, and then which made Katappa kill Bahubali. That's it. So this is what is happening in our immune system, correct? So next topic, we'll go on to when to order ANA and avoiding a shotgun approach. When I saw this shotgun, I don't know what is a shotgun actually. I was thinking, I was looking for literature, what is shotgun approach and all. So, but that what literally meant is a shotgun is this thing. That's it. It's a pellets. It's like hitting multiple people at like a person at multiple targets. Like if you want to kill a bird, you just want to target eye like Arjuna, but you can't kill it because you don't have skill of teaching. You use a shotgun with multiple pellets, and then that bird is dead anyway. So this is like a shotgun approach, which you will not do it with precision. You do it in a broad perspective. So trying too many things at once without precision, hoping something works. So this shotgun approach is true in rheumatology, because whenever, see, if you don't have any idea of whatever the antibody, as sir said, which method or which antibody or which diagnosis you are expecting and which methodology or which lab test to be ordered, you will end up doing multiple investigations, which burns the pocket of the patient, as well as, and you will not be able to have a diagnosis, and you will have a false positivities, and you will be going in another direction. So I remember a patient who has been treated as psoriasis for 6 years down the line in NIMS. 6 years she has received IL-17, secukinumab, everything, and now she had come to me after stopping the medicines. So she has come to me with myositis. So they have never done an ANA profile, because in psoriasis we don't do an ANA profile. So what happened was, this patient was an anti-synthetase syndrome. In anti-synthetase syndrome also, you'll have a psoriasiform rash, which is there, which they have been treated as psoriasis, and then now she has evolved into a anti-synthetase syndrome. So you'll have these things in rheumatology. So I'll go through a case scenario. You have a 36-year-old woman presented with complaints of tiredness. She has family history of SLE in her sister and maternal aunt. This is my classmate. This is my classmate who has called me for this. She's understandably worried about lupus because the family history, and is asking to be tested for it. So she was calling me, why should I undergo an A and should I do an ANA? Because her two sisters were diagnosed with SLE. One has lupus nephritis and other was a mild disease. So would you do ANA? Would you do? So what is your pretest probability in her? Is there an indication actually? So being a family member having a SLE without you having any clinical features, is there an indication for doing an ANA? No, right? So what I did, I have examined her. So I was asking her, she didn't have any polyarthralgia. She has no extraarticular symptoms, skin rashes, oral ulcers, any CTD, connective tissue disease feature she doesn't have. So clinical examination features also were unremarkable. So physician, by the time she came to me, some investigations were there which has showed positive thyroid peroxidase antibodies, which is showing, this is called a local autoimmunity, or organ limited autoimmunity. This is not a systemic autoimmunity. This is an organ limited autoimmunity. Maybe because of this family history of autoimmunity, there is something called polyautoimmunity. You will have thyroidism, you will have SLE, you will have diabetes as well, which is called a polyautoimmunity. So this is an organ limited autoimmunity. So since she was pestering, so we have done an ANA. ANA showed 2+ fine speckled, and then negative for anti-dsDNA and anti-ENA, extractable nuclear antigens, was negative. Okay. So what you will label her as? Is she SLE? No. She doesn't have any clinical features for SLE. Her ANA is 2+ fine speckled. Other things are negative. So this 2+ fine speckled is probably secondary to the thyroid peroxidase antibodies which are there, because of the, as sir said, there are so many antigens which are there inside the cell of a hepto cell line. You have a single cell, you will have nuclear, cytoplasmic antigens, you have so many things which are sitting. So you, because of that, your nucleus takes some uptake, 2+ fine speckled, you will have an ANA profile negative. So in JIPMER, actually, we do microscopy actually. So what we do is, any 2+ fine speckled, so we should do an ANA profile. So then what we do is, we go back and see, take the history, and if their history is significant, then we go for an ANA profile, because of the, we wanted to decrease the burden on the system actually. If 2+ fine speckle or anything below 1+, 2+ and below, you will get an ANA profile as negative. This is not true, because there is inter-observer variation, lab variation as well. So this anti-thyroid peroxidase antibody, INA positive, is due to anti-thyroid peroxidase antibodies. So what happens if you do ANA indiscriminately? So day before, I had a call from a pathologist who owns a lab in Vizag. His sister was complaining of vague shoulder pains and backache. Since it is available, he has done an ANA and ANA profile for her. So ANA came 1+ speckled, and ANA profile showed Rho 52 positive. So now the tension started in the family. His sister is a software engineer. She started searching Rho 52 antibody in ChatGPT. and you will have a rapidly progressive ILD, which is there, which is associated with row 52, which is highly associated with mortality. Now the confusion starts. So what happens? So if antinuclear antibody test is requested indiscriminately, the positive predictive value of lupus is only 11%. And whereas if you have a pre-test probability, the probability will increase up to 85 to 90%. So should be requested only when pre-test probability of lupus or other connective tissue diseases is high. And then positive predictive value increases by two folds when you have a clinical picture and then you do an ANA profile. And when you have two or more organ systems, your value increases. So you did a shotgun approach in her, correct? They have done an ANA profile. Now diagnostic confusion. Now the confusion is row 52 is associated with Zika symptoms. If you ask any software engineer, they'll say dry eyes. So you don't know now what you have to treat them. You should not treat them. You never know. So I'll end up giving HCQ, which is not required for her mostly. So because she has studied a lot, and then I'll just taper her off over 3 to 6 months, and then she will become hyperpigmented because of that HCQ. So this is a consequences which will happen when we do an diagnostic or a test which is not necessary. And then you have high false positive rates. As sir said, you in a general family, if all of us get tested, out of 10, 1 or 2 or 3 will get positive for an ANA. And then there is a wasted cost. So that ANA profile and ANA need not be done. So it's around 4,000 to 5,000 bucks. And then unnecessary anxiety to stress to family. So I have one pediatric mother who had done ANA to her daughter because she himself is SLE. She herself is an SLE, so she had done her daughter out of enthusiasm, and daughter had multiple antibody positivity. Now she starts coming to my OPD and starts crying. So every time my energy goes away in just counseling her. That's it. Nothing. I won't start any medicines. I'll just counsel her. So when you have this pretest probability of this type of patient, you have a malar rash, you have oral ulcers, which is there in a 34-year-old, which is photosensitive rash. It's a no-brainer actually. It's an easy to diagnose. And you have ANA with 4+, fine speckled, and ANA blood showing DSDNA 3+, SSCA 2+, and SM 3+. So this is whenever you have a pretest probability, your value or your diagnosis will help. And the lab also correlates well. So when to order an ANA? So order only when if clinical suspicion exists or SLE. So these are the manifestations like where you have rash, arthritis, cytopenias, when you have 2 or more organs in doubt, and you have Raynaud's or skin thickening, when you have dry eyes and dry mouth. This is not for everybody. If their dry eyes and dry mouth is documented by an ophthalmologist for dry eyes. And there is any proximal muscle weakness, rash, and ILD in mixed connective tissue disease in overlapping features, autoimmune hepatitis, and JAA. So all JAAs ANA should be done because they'll have who have ANA positivity will have high risk for uveitis, and there is a particular structured protocol by which they have to be followed uveitis screen because they'll have asymptomatic uveitis leading to cataracts in them. So when not to order an ANA, this you should be knowing. So no healthy individual should be screened by ANA. So in Apollo, when I had joined, so my superintendent has asked me, we'll have an ANA screening, we'll have an autoimmune screening panel for everybody by doing RF anti-CCP and ANA in health checks. Health checks, like usually in corporate, what happens is the companies gift their employees with health checks, which is done free at Apollo. So he asked me whether we can include RF anti-CCP and ANA. So I told him no, because you will just increase the burden and anxiety to the patient, which they are not diagnosed with and not suffering with. So avoid for non-specific symptoms. As I said, in that pathologist case, you have bilateral shoulder pain, vague pains. You have to avoid doing ANAs. And isolated arthralgia without inflammation. If there is no arthritis, without they just suffer with arthralgias, so ANA need to be avoided, except you have other organ involvement as well along with that. And family history alone is not an indication. I think I would have reinforced that by 2-3 times. So family history alone is not an indication for doing an ANA. and elderly without clear autoimmune features. Like if you have a mother who had given birth to 2 3 individuals, and then who had received multiple blood transfusions, or an elderly individual above 50 years, so these patients should not be, these people elderly should not be tested for ANA, because if they don't have any autoimmune features, they'll have ANA positivity. And do not repeat ANA for monitoring. So you have a titer of 1 in 640, there is no point in repeating ANA. So after some time, so I usually tell my patients that ANA is done once in your lifetime, so keep that report safe. So avoid ordering ANA without ANA. So whenever your diagnosis is not clear, just go for ANA by IFA standard method, and then go ahead and do an ANA. So if your ANA is positive, then you are justified in making the patient spend around 2,400 rupees for the ANA, or else directly spending 2,400 on an ANA, and which comes to be negative, is no point actually. So why N is not relevant in ANA anymore in ANA? Who is this? Who is this? Somebody said. So you were skeptical, right? So some people were skeptical. So when I see this, you know that he's Pawan Kalyan, correct? So similarly, it's easy. Your device turns off. 44 seconds, your device turns off. So now if you anticellular antibody, if in ANA, if you see at only nucleus, you will see for nuclear patterns, you will see nuclear patterns. That's it. You will not see for anything. But there is a lot sitting outside. There are centrioles, there are Golgi apparatus, there are mitotic spindles. There are so many things which are sitting outside the nucleus, which are still an antigens of choice. So antigens which are there, which need to be detected in particular diseases like myositis or Sjögren's syndrome. So did you anybody of you think when sir said rho 52 is less in ANA IFA, did you ask a question why? Did any of you think why? If you don't think why, you will never know, you will never remember it. Why? Because what is the fixative they use in Hep cells, Hep cell lines? I think sir will be telling in the evening. What they use for ANCAs, both fixatives are different. So whenever they fix it, the rho 52 is a predominantly a cytoplasmic antigen, and it the solvent what sir is going to tell is that formaldehyde for ANA. So it dissolves the rho 52. So hep 2 2000s after that. So they have transfected these cell lines with rho 52 virus. So then the rho 52 expression increased. So that has changed actually what sir said. Rho 52 was low in 2000 cell line. After the 2010 cell lines onwards, they started transfecting these hep2 cell lines with more with a vector, virus vector, which will increase the rho 52 expression. Still holds true for the Jo1 antibody. So that's why you have to rename this ANA as a anti-cell antibody. So traditionally, you will have these patterns: homogeneous, fine speckled, coarse speckled, nuclear, centromere patterns. So after, along with that, you have now cytoplasmic patterns as well as a mitotic patterns as well. So why cytoplasmic patterns matter? Because many significant antibodies are still there in that. So as sir said, rho 52, which is predominantly for Sjögren's, which migrates from cytoplasm to nucleus. It jumps between cytoplasm and nucleus because some patients still can have rho 52 positivity depending upon the cell cycle. And then in myositis, you will have Jo1 antibodies. You ever heard of anti-synthetase syndromes? No, there are some other antibodies like PL7, PL12, EJ, OJ. These are all involved in protein synthesis. So these antibodies are directed against different parts of the ribosomes. So whenever these antibodies are there, they are there in the cytoplasm. So whenever you have a patient with inflammatory myositis, you do an ANA is negative, and you should not negate the point that this patient, if you do an ANA profile or ENA profile, that comes negative. Now that they have included J1 into that, but if the patient is having a PL7 or PL12 antibody, this comes negative. As sir said, if you have ANA negative, ENA profile negative, you should not negate the point that patient is not having any autoimmune disease. So you have to look for the cytoplasmic patterns as well, because the cytoplasmic pattern gives more information along with the nuclear patterns. So these are some examples. Reticular pattern, which is predominantly for the mitochondrial staining, which is there for primary biliary cholangitis. Fine speckle, you can see with cytoplasmic fine speckle. This is cytoplasmic fine speckle, Jo1 and synthetase. There is one thing, a fine speckle with SLE as well. If you have a RiboP antibody positivity, these patients will have cytoplasmic speckle. And dense fine speckle, GWDFS70, as I said, this is called a healthy autoimmunity. When you have a DFS70 antibody present, we say, irrespective of multiple antibody present, even if they have a DFS70, this is called healthy autoimmunity. And if there is discrete dots, what I was telling, it is ribosomal P. This previously we were telling them as cytoplasmic fine speckle. And then fibrillar pattern for autoimmune hepatitis and liver. There are other mitotic patterns as well, which are significant, like centrosome, spindle fibers, pneuma-like, and intercellular bridge. And pneuma-like pattern is seen in Sjogren syndrome, SLE, and undifferentiated CTD. So pneuma-like pattern is reported in our India actually. So this was surprising to me. I had presented a case of pneuma-like positivity in Delhi to a UK SLE cohort ma'am. So she was telling she never seen a pneuma-like pattern. And then she asked the audience how many of them had seen pneuma-like pattern. Out of 100, 60 people raised their hands. So pneuma-like pattern is being reported in India because of what we are following a structured methodology because of the ICAP system. So the negative nuclear trap happens because the same case, what I was telling, 38-year-old female presented with subacute proximal myopathy, interstitial lung disease, and mechanics hand. ANA is reported negative, but anti-Jo1 is strongly positive. So this reinforces the fact that if you see for only for the nucleus and only nucleus is reported, you will get into a trap and then you don't diagnose the disease. And the negative report is not false negative, it is a reporting failure. So this is a diagnostic blind spot, what we are having, and you'll miss several diagnoses like antisynthetase syndromes, you'll have primary biliary cholangitis, juvenile onset myositis. These all are missed if your cytoplasmic pattern is not reported. And you should follow a reporting standard whenever it is recommended. You should give a cytoplasmic pattern, even if it is there or not there. So the path forward is that adopt the term anti-cell antibody. This will become a next consensus now. And then ensure universal implementation of ICAP codes and start reporting all ANAs into like AC patterns. So this we were discussing with Vijaya Diagnostic Center, not the Vijaya Medical Center. So last year we had discussion with the pathologist and we started reporting all from Vijaya Diagnostics as AC patterns. And promote comprehensive reporting of nuclear patterns, cytoplasmic patterns, and mitotic patterns, and standardized reporting across laboratories, which will improve diagnostic accuracy. As I said, if the patient from here goes to US and then their ANA is done, they should not have any confusion of the pattern what we are reporting. So better interlab consistency and uniform clinical interpretation, it will help. So the ideal report should contain a titer, a nuclear pattern, staining pattern, cytoplasm staining pattern, nuclear staining pattern, and mitotic pattern, intensity, final pattern should be written along with the code, ICAP code. So in conclusion, breakage of tolerance is the one which is leading to a development of autoimmunity and autoantibodies in patients. And never do a shotgun approach. And if you do it, you'll be burning hands, you'll be burning patient's pocket as well. And there's a high pretest probability will lead to more specificity in diagnosing the autoimmune diseases. And you have to know when to not order ANA, because as Sudhir was telling in the morning, this ANA can be done in Narsanpeta as well. It can be done in whatever remote place you can think of because of the Thyrocare lab availability, and they just ship it. So you should know whenever you should not use your pen, not to use order an unnecessary test like ANA. So cytoplasmic and mitotic patterns, I think I have made my point. Like it is important. So it has to be reported in every ANA. Thank you. I'll be happy to answer any questions. it will be there, ma'am. So that's why again you should have to see the clinical context. So recently we had one person who had dengue. After that he had gangrene in right lower limb. So his antiphospholipid antibodies came high titer positive, 200 everything. And he had went for an amputation. Now the question here is, if he's antiphospholipid antibody positive, he has to be on warfarin. If antiphospholipid antibodies are negative, he can be started on DOAX. So this patient, the ideal thing what should be done is, we have repeated his antiphospholipid antibodies after 12 weeks. It came negative, and then we have switched him to DOAX. Why I am telling this is, warfarin, if the patient has been started on warfarin, he has to be monitored with PTINR every month. So this is a burning pocket again for the patient, and warfarin also has high risk for bleeding tendencies as well. So when we start DOAX, this is less chance. So this patient, this is because of a infection. You have that, you will have autoantibody producing, which is produced. That's why in ICUs you see many patients who have multiple autoantibody being positive, but this has to be interpreted in the clinical context rather than just taking the antibody and then treating them. So this has happened to me in one hospital, a young boy who was diagnosed as vasculitis, and he had Pianka positivity. And he was given, by the time I went, he received pulse steroid and cyclophosphamide as well by a nephrologist. So actually he had an infective endocarditis, which caused a Pianka positivity. So then he expired. So, so autoimmune diseases particularly related to interferon pathways, because COVID has tapped hyperimmune response in the interferon pathways. COVID, SLE, myositis, these three acts through interferon pathways. So post-COVID, there is an increased evidence of reporting of SLEs as well as inflammatory myositis. Other autoimmune diseases, they are not particularly able to track of, because rheumatoid arthritis prevalence has not increased. It has been the same, but inflammatory myositis per se, it has increased post COVID. Ma'am. Not necessary, no, ma'am. Like if you have an infection, like in Apollo, what they used to do is, whenever they suspect an infection, they treat the patient for a while, for 1 to 2 days. If they're not improving and they have two organs involvement, again a transaminitis with AKI, or he is confused with AKI, in that case they used to call me. So then in that case, I used to do a specific, any investigation tailored to that, connecting that syndromic approach, and depending on that we used to do. If the AK is there, I'll go more in the line of anchor rather than doing for an ANA like that. Thank you.
Thank you, sir, for such enlightened speech. You made the complex topic in very simple way and of course in entertaining way also. Thank you, sir. Now our next session will highlight the relationship between ANA testing and kidney involvement in autoimmune disease. This topic will cover lupus nephritis, autoimmune mechanism affecting kidney, vasculitis syndromes, and clinical correlation between lab and nephrology management. So, for this enlightening us this topic, it's my pleasure to invite Dr. Anjani Madam, consultant nephrologist, GEMS Hospital.
Good morning, everybody. I am Dr. Anjani. I'm a nephrologist here at GEMS. So I think extensive discussion has been done on ANA and everything. So I'll just brief it out how we are using ANA for our kidney. That's all. So we all know autoimmune diseases. Basically, the thing is not only antibodies, it could be an aberrant T or a B cell. So there is an aberrancy in T and B cell signaling, which results in autoimmunity of that patient. And this can occur in all ages, but most commonly seen in women because of hormonal influences. And the most prominent amount thing is production of autoantibodies. And these antibodies help us to diagnose, treat, and also they have a role in disease pathogenesis. They're more important in monitoring therapy so that we can identify easily flares and remissions. So what does an autoantibody actually do in the body? So this autoantibody can either act as a receptor agonist. Example in Graves' disease, where it causes hyperthyroidism, and next is receptor antagonist, like in myasthenia gravis, or it can act as a ligand antagonist, especially in immunodeficiencies, or it can cause cytotoxicity, like in hemolytic anemias, or it can cause neutrophil activation, which predominantly we see in ANCA vasculitis, and is acantholysis, like conditions like pemphigus. Then how does this autoantibody affect the kidney? Mostly it is because of the formation of immune complexes either outside the kidney or within the kidney. So these systemic immune complexes can be formed in the peripheral circulation, which can be deposited in the kidney. Then why does kidney take the maximum brunt? Because it is 20% of the cardiac output is always going through the kidney every minute. And moreover, it has a very high flow, a selective permeable system of filtration along with the glomerular basement membrane, which has a negative charge. So it will attract all the positive charge complexes when it is filtering through that glomerulus. So this is the reason, depending upon the size and charge of these immune complexes, while they are getting filtered through the glomerulus, they can deposit in various places like endothelium, subendothelium, glomerular basement membrane, or on the food process. So it is basically the size and charge of the immune complexes. As I said, these systemic immune complexes, they can get deposited while they are undergoing this filtration process. In addition to this, you can have either a systemic antigen, which is filtered and planted in the kidney, or you can have a local antigen in the glomerular basement membrane or in that in the glomerular basement membrane, which acts as an antigen and which attracts your antibodies. So this is how the immune complexes get deposited in the kidney. And once these immune complexes are deposited in the kidney, it leads to complement activation and further damage. So if you see, all autoimmune diseases, they are actually a combination of genetic, epigenetic, and environmental factors. So in the course of an autoimmune disease, this is a trajectory which develops over time. So you have a phase of a predisposition, which is usually a genetic predisposition, which causes an aberrance in your T or B cell. And over time, what will happen? The patient will land in a state of benign autoimmunity. So this benign autoimmunity is a predisposition which becomes a manifest. So you have an abnormal antibody or an abnormal T cell system in the patient's body, but the patient is not developing any symptoms. So this is a benign autoimmunity. Then the patient goes to a preclinical autoimmunity. Here the patient might develop that symptom, but it is not so significant enough for you to order tests or for the patient to seek medical attention. So this benign autoimmunity, as Sir said, sometimes it can come as positive. We don't know whether it will go to a disease or not. So it has to go through a phase of preclinical autoimmunity where it will start with minor symptoms, and then it comes a stage of autoimmune disease where you have florid symptoms of established connective tissue disease. And here you order tests more, you diagnose, and you start treatment. And post-treatment or with time, it goes into a phase of post-clinical autoimmunity. So mostly the patient with treatment can go into a remission. The level of autoantibodies can decrease. So we use autoantibody levels, but the best, this is the SMART criteria which has to be used for the utility of an autoantibody. So it has to be, whatever test you are using, it has to be more specific. So it should tell you whether it has a disease or not. It has to be scalable. The performance of that test should be measure. It should be able to handle increased workload or a decreased workload also. It has to be a good measurability has to be present, and actionability, like it has to be clear and unambiguous, added value and realism. It should add something to the clinical picture. It should not tell something out of the picture and confuse you more. And it should quantify your clinical response also. That is considered as a very good autoantibody assay. So already sir has discussed. Traditionally, we did the direct, indirect immunofluorescent assays, which are directed more towards nuclear antigens. But recently, we have started doing this more specific assays, which is extractable nuclear antigen testing, and we order a panel of antibodies. So anti-nuclear testing is best for screening, but this specific tests are more important once you have an ANA positivity. So this also has been discussed by my previous presenters. Um, the best screening test would be to do an indirect immunofluorescent assay using Hep2 cell line, because that is a cell line which has a very large nucleus. So it helps us to see the staining pattern much more clear. But what are the disadvantages? It is labor intensive and needs technical expertise. Reference sera are less, and titration is needed, and it does not tell you what is a specific antibody. So based on patterns also, we can identify disease. This already has been covered. So the next is solid phase immunoassays, where we order more antigens are plated on are prepared and immobilized on a solid surface, and we can identify a specific antibody. This helps us to identify a disease and start treatment. It is also semi-quantitative, but most important thing is it lacks sensitivity. So whenever we see a case of lupus, so as everybody, as all of you know, most important is clinical features. So if we have a clinical feature, then only we should order an ANA test or a specific antibody test or an ANA profile. So for our kidney, certain things are very important, like anti-dsDNA, anti-C1q. This will tell you the level of injury which is occurring in the kidney. The titer is proportional to the degree of damage. In the first diagnosis, when the patient comes with lupus, usually we do a biopsy, and we do a biopsy. Usually we report the activity based on that class 3 or 4. There are different classes, and based on that we target the treatment. But in the follow-up of these, like what do we do a treatment of lupus nephritis is, we try to reduce that antibody production or the maximum disease activity to a minimal level by giving some drugs for induction. And once the disease is under our control, we continue immunosuppressive therapy for certain period of time as maintenance. So that first you are bringing this exaggerated immune response into a controlled acceptable level, and then you are maintaining that low level in a very long, for a long period of time. So this is called induction and maintenance. Usually induction therapy is given for 6 months, followed by maintenance therapy, usually given to 3 to 4 years. That is what we do for lupus nephritis. So in this time period, by the time we get that control into our hands, sometimes that patient might have flare, and it might not be possible to do biopsy again and again to know the level of degree of nephritis in the kidney, and to diagnose flare and to monitor that flare. Most important things we can do is anti-dsDNA titer and C1q antibody. C1q is not so widely available at our place, but anti-dsDNA titer, with that we can identify whether the degree of injury is getting controlled or not. Anti-Smith antibody, though it is present in 25% of the patient, this is more specific. So somebody who is ANA positive, dsDNA might or might not be weakly positive, but Smith positive, you should consider it as lupus. And next is RNP, anti-RNP, usually seen in overlap syndromes. This anti-SSA or anti-Rho is seen in 30% of the patients, but most important is seen with neonatal lupus and congenital heart block. So if it is there, and if your patient is a prospect, is a reproductive age group female who's trying to get pregnant, you should be very careful. Next is anti-histone antibodies, most commonly drug-induced lupus, which we see. Anti-erythrocyte for hemolytic anemias, it is not so specific, and anti-platelet antibodies for thrombocytopenia, And presence of anti-neuronal and anti-ribosomal antibodies can help you to identify CNS lupus. Next is Sjogren syndrome. This is usually a disease of exocrine glands, which is causing keratoconjunctivitis sicca and xerostomia. Renal involvement here only because of these antibodies, it would be 75%. Most would be an antibody to the tubules, distal tubules, causing a distal RNA, distal RTA type of picture. So young female who presents with distal RTA, most likely you should suspect Sjogren syndrome. And then you can order your tests. So 20% of the patients will have renal involvement, and it can identify 75% of patients presence of renal involvement will identify your diagnosis. So that is much more important. More importantly, it can present with acute or chronic tubulointerstitial nephritis, and a proximal RT or a full-fledged Fanconi is very rare. But this can be diagnosed with the help of anti-SSE and anti-SSP. So renal involvement, distal RTA. These are the two pictures you should involvement. Young female who presents with distal RTA, always rule out Sjogren's. For that, we have to order. Anyways, we have to confirm clinically with involvement of eyes and this. But most important thing, if you do a CTD profile, you can get anti-Rho and anti-La positive. Systemic sclerosis. So pathology here is tissue fibrosis with obliterative vasculopathy, and patient might present with Raynaud's, and pulmonary fibrosis, hypertension are common. Dysmotility, scleroderma, renal crisis. So you can have a limited involvement or a diffuse cutaneous involvement, and limited cutaneous involvement, we classify this as CREST, where there is calcinosis, Raynaud's phenomena, esophageal dysmobility, sclerodactyly, and telangiectasias. Renal wise, these patients, they present with accelerated hypertension, so malignant hypertension, a very high BP, and this is called as scleroderma renal crisis. The patient presents with a rapidly progressive renal failure, and biopsy will show you a thrombotic microangiopathy. So we should not get misled by this TMA picture with again HUS TTP like pictures. This is a different scenario. Young female who presents with unexplained hypertension, which is progressing to a renal failure. You should always suspect scleroderma. The involvement could be also treatment related, like penicillin related membranous nephropathy and scleroderma associated vasculopathy. And some patients, we can also have MPO positive vasculitis also. ANCA vasculitis also can occur. So in such scenarios, anti-centromere will help to diagnose a limited cutaneous scleroderma, and anti-topomerase 1 is much more specific for diffuse cutaneous. And anti-centromere antibodies also tell you we have to be careful about lungs also, because pulmonary hypertension and peripheral vascular disease are more common with anti-centromere antibodies. Next is polymyositis or dermatomyositis, inflammatory myopathy. So this is a myopathy because of inflammation, which is occurring because of autoantibodies. In dermatomyositis, a complement-mediated microangiopathy could be because of a malignancy or an overlap syndrome. Polymyositis, it is because of CD8 plus T cells infiltration. Renal involvement, because of myopathy, you can have release of myoglobin into the circulation, causing myoglobinuria and rhabdomyolysis. So this causes an acute kidney type of picture. And chronic glomerulonephritis can occur, and rarely you can also see MPGN and membranous type of picture. The identifying antibody, anti-Jo1, which is 20% disease prevalence and cytoplasmic pattern. Mixed CTD, usually either patient presents with either a rheumatoid picture or a lupus picture, and over time it develops into all clinical manifestations. This is mostly identified with the help of our NA profile only. So where the patient will have multiple antibody positivity, most importantly, anti-U1 RMP positivity. So the presentation could be because like lupus nephritis or because of scleroderma. Next is rarely, this topic is actually very extensive. So our autoantibodies are involved in only two things. One is ANCA vasculitis, and the pathophysiology, as Sir said, it's because of NETs, neutrophil extracellular traps. The renal presentation in all kinds of vasculitis is only one. It's a crescentic glomerulonephritis. So whenever a patient who presents with clinical picture, your clinical picture would be somebody who presents with a renal failure of severe advanced renal failure, but has protein in the urine and also has an active urine sediment. So it is a mixed nephrotic, nephritic, AKI related picture. There you should suspect renal, rapidly progressive renal failure, and your biopsy, if it shows a crescent, it's a rapidly progressive glomerulonephritis. So crescents could be of different types, different causes. How do you identify what is the cause? Based on the immunofluorescence of the tissue pathology. So whatever biopsy sample we do, on that we perform an immunofluorescence. And the pattern of immunofluorescence will tell you what kind of a vasculitis is it. The pathophysiology is the same. Immune complex deposition is occurring in the vessel walls. That is what is vasculitis being. When it occurs in the kidney, it is causing vasculitis of the renal arterioles. Okay, where small vessels of the kidney. So here you can have either a posse immune type of pattern where there are no immune deposits in your immunofluorescence. That is called oncovasculitis. Or you can have an immune complex deposition in the vessel wall, which could be of various causes. Like I said, could be because of IgA. So if it's a predominant IF related IgA, then it is an IgA crescent, IgA crescentic vasculitis or HSP. Next is cryoglobulins. Cryoglobulins are specific autoantibodies which are present in your body. Elderly people usually we see. And if it is positive, you can have a full house type of pattern. And SLE, you can have a full house. You can have IgA, MG, and lambda, kappa, C3, C1q. All these are there. So presence of C1q will tell you it is a systemic immune complex pathology. But absence of C1q will tell you it is a kidney located pathology. And hepatitis B and C also same pathology in MPGN. So in all these conditions, what you see a systemic immune complex which is getting deposited in the kidney, vessel walls and causing vasculitis. So mostly autoimmune diseases are very low prevalence, and in the general population, ordering tests for everyone is not advisable. The positive predictive value is poor if you do not have a clinical scenario. So you should not apply this to the general population. And the test only adds value in the presence of a very high pre-test probability. So a clinical scenario where you're suspecting an autoimmune disease, then only if you order an ANA, it will be much more helpful. And this result also has to be carefully interpreted only in the clinical background. So you cannot treat a report. You should always treat a patient. So as already sir told, ALS testing is not helpful in confirming a diagnosis of rheumatoid arthritis or osteoarthritis. Should not be used in such conditions. This is not recommended to evaluate fatigue or back pain or any other musculoskeletal pain unless you have a clear-cut clinical feature of a CTD. This should be only ordered once, ANA testing, and positive ANA test need not to be repeated. So somebody who's positive, usually we don't repeat. And negative tests have to be repeated only if your clinical suspicion is growing. Thank you.
Thank you, madam. She's a very busy consultant in our hospital. Okay, she's our greatest pattern also for our ANA testing. So yesterday C3 C4 testing, the first sample was because of madam only. So we streamlined ours and we started off. So next HLA B27 also, I think madam will be our first pattern. So we are very thankful for madam for our constant support to us, especially in starting of ANA testing. And from a very huge outsourcing, this completely went insourcing. Okay, so we are proud of that completely. Now a small felicitation. I request our superintendent sir and Sugneshwari madam to come onto the stage to felicitate Anjani madam.
Thank you, sir, and for those kind words. I'm not so busy, sir. I can take time. Second thing is, sir is actually very like me only. How I am with the patient, he's with the test. So whatever doubt I have, I always call sir, and he also calls me back, and we discuss, and together we operate. And I think availability of ANA testing and C3 C4, it's very useful in our hospital, sir, actually, because it will cut down most of the time, and most of the unnecessary immunosuppressive treatments which we are giving, I think we can minimize also.
Our next session will address a particular questions in ANA testing. It will emphasize on why does screening dilution matter? Should laboratories use 1 is to 80 dilution or 1 is to 160? How this interpretation will help in diagnosing pediatric versus adult patient. This discussion will help us to understand in detail about diagnostic sensitivity, specificity, and clinical significance. This session will be moderated by Dr. Sugneshwari Madam, Professor of Department of Microbiology, and I request Dr. Sai Kumar sir and Dr. Swami Naidu sir to come to desk.
Sangeet, you can call Madam also. Anjani Madam also.
Anjali Madam, I request Anjani Madam also to join us.
So, respected dignitaries and dear delegates, a very good afternoon to you all. First of all, I would like to thank our organizing chairperson, Dr. Nitin Mohan sir, for giving me the chance to moderate the debate session. So, today's debate addresses a very practical clinical dilemma. What should be the optimal screening dilution for ANA testing 1 is to 80 or 1 is to 160, especially when interpreting results in pediatric versus adult population? While 1 is to 180, while 1 is to 80 increases sensitivity and helps detect early disease, it also raises concerns of false positivity. On the other hand, 1 is to 160 improves specificity but risks missing early autoimmune disease. So, this debate is not just academic, it directly impacts the clinical decision making. So, now I will begin the debate to gain some insights from our experts. So, I will start the first round, sir. So, my first question is to Dr. Swaminaidu, sir. In children, should ANA interpretation rely on fixed dilution cutoffs or should it be primarily guided by clinical context and risk prediction?
Good morning, all. In children, most of the Y2s and ANA profile, that is important actually, because most of the children have bony pains, like a growing pains will be there. So growing pains are non-specific. So the parents will come, pains are not reduced by the painkillers, repeatedly coming pains. So we are sometimes we are ordering ANA, first of all ANA and test later, if ANA positive, later will be ANA profile. First of all, so 1 is to 80 versus 1 is to 60, but we will consider if it depends upon clinical scenario. If a clinical scenario is fitting into autism disease, we will consider a 1 is to 80 also positive. First of all, which disease is important actually? If the SLE, you are suspecting SLE, 1 is to 80 also we can take a positive. Because SLE, because sensitivity of ANA profile is more than 90%. So
Check.
if it's
Hal.
so if we suspecting SLE, if the sensitivity of ANA profile is 1 is to 80 or 80 also will take as a positive. But sometimes ANA profile may negative, but clinical scenario fits into autism disease, will send for specific ANA profile. So next we'll consider 1 is to 80 in a juvenile rheumatoid arthritis. Juvenile rheumatoid arthritis, mostly it is mostly confusing because juvenile rheumatoid arthritis, there is a polyarticular and oligoarticular there. In polyarticular, there is no confusion most of the time in involvement more than 5 joints with the fever, anything there. But oligoarthritis with suspecting juvenile rheumatoid arthritis will send ANA. But because why ANA means ANA not to diagnose the juvenile rheumatoid arthritis, ANA diagnose the eye symptoms. Because ANA profile, if it ANA 1:80 dilution also, will refer to ophthalmologist for the slit lamp examination for anterior uveitis. Next, if we juvenile rheumatoid arthritis started before 6 years, mostly 90% they will future they will develop anterior uveitis that leads to cataract, glaucoma, everything. That's why patient clinical scenario is important. If it is juvenile rheumatoid arthritis, oligoarthritis, patient less than 6 years, ANA less than 8, if 80, sometimes 40 also, we'll suspecting, we'll refer to pediatric ophthalmologist or ophthalmologist for the uveitis serial periodic anterior slit lamp examination. That is important. Next one is where ANA will not useful in our pediatric population, mostly neonates. Neonates may present with neonatal lupus or neonatal bradycardia. The two scenario, neonatal lupus because of the from mother to baby antibodies transfer from the transplacentally passive antibodies. So that time maybe child may present with hard blacks or bradycardia, that is clear cut. Some cases what we are daily encounter is child present bradycardia, mother has no history of lupus. That time also we'll send ANA with ANA profile for Rho and law antibodies. According to that we'll treat. If it is mother, this is one scenario, neonatal lupus one scenario, clear cut, there is no clear mother, all SLE is there, child also present with malar rash, bradycardia, trans liver involvement, so we'll definitely treat with according to IVIG will give. Later sometimes baby is bradycardia, mother having no SLE, will treat according to, we'll send ANA profile, Rho and low antibodies. If not negative, we'll treat on the other diseases. Next scenario is already previous children, mother have previous SLE, already previous children also SLE. So second pregnancy, how to approach the second pregnancy? Already mother having first child, mother having SLE, first child delivered, a second pregnancy, came to antenatal checkups. That time we are 16 to 18 weeks. We'll see the mother ANA profile. Next, we'll see the fetal echo. How is the fetal echo? Because sometimes child present with fetal bradycardia that leads to hydrops and fetal death also. That times 18 to 16 weeks we'll do fetal echo. Then we'll fetal echo suspecting each neonatal bradycardia, neonatal lupus. We'll start to dexamethasone for the mother. Sometimes we'll start hydroxychloroquine also. Serial fetal echocardiogram, every monthly fetal echocardiogram. If it is fetal baby developed neonatal high drops, will terminate the pregnancy, deliver as early as possible. That is a from pediatric perspective user. So what I'll understand is clinical scenario is first. Later, so 1:80 with clinical scenario fits into your diagnosis, you will take 1:80. Sometimes that dilemma, it will take 160, sometimes 320 also will take that. That's all. Thank you.
Thank you, sir. That means we need to always confirm the ANA titers with the clinical symptoms.
Clinical symptoms.
Okay, sir. Thank you, sir. Dr. Swaminathan, sir, a consultant neonatologist who bring a pediatric perspective to today's discourse. Sir, thank you for making time today on holiday. Thank you, sir. So now I would like to ask Dr. Sai Kumar, sir, rheumatologist. What is the influence of ANA dilution in autoimmune disorders? Could you share your thoughts on the role of ANA in diagnosis of autoimmune diseases, sir?
So,
Already.
So good afternoon now. So ANA titers, actually why the concept of ANA titers has come is because the same thing what we have discussed, because out of 10, 3 can have ANA positivity as we said. So if you use a titration of 1 in 40, 1 in 40 titration, this can increase as high as 6%. Like you have out of 10, 6 individuals can have ANA positivity. So that's why a standard recommendation has come based on the serial population studies or retrospective population, retrospective sample studies, whom they have diagnosed as an autoimmune disease, what they have found out is that when you use a titer of 1:80 and above, the prevalence of these false positive decreases to 19%. So this has been proved in India as well. Delhi AIMS has conducted a study, and from Peerless Hospital, West Bengal, you have a study. These two studies which have shown that when you use a titer of 1:80, your false positivity decreases to 19%. Now there is a study which is being done in West Bengal using a titer of 1:100. They have serially following the patients. They are doing it 1:80 and 1:100. So now the question comes: is there a point you want to still, you have a patient with SLE, you have diagnosed with 1:80 titer, and you have a strong clinical history? Is there a point that you titrate this sample up to 1 in 1640, 1640 titers? If you do, if this comes positive, is it clinically significant? For me, no. For me, no. So if it is 1:80, patient is having a major organ involvement, I'll treat them as per the guidelines. If 1 in 1640, if the ANA titer is still positive and patient doesn't have any major organ manifestation, if she still has a mucocutaneous manifestation and just an oral erosion, I'll just give with just a prednisolone and HCQ, and I'll try to taper NC without giving any immunosuppression if there is no major organ involvement. But high titers will tell me that these patients may have a risk of higher end organ, when major organ involvement, which keeps my antennas ready to search for any organ involvement every 3 to 6 months. That's it. So rise in titers or elevated number, like high titration values, doesn't give me any extra value, according to me. This is what we are practicing also.
One thing, if once ANF, if you diagnose 1:80, clinical symptoms are already started, so you started treatment. Later, whether repeat ANF profile or another markers?
Not necessary. Not necessary. So ANA once done, it's done. There's no point in repeating the titers or seeing the titers or repeating an ANA.
Treatment response also, there's no use.
There's not.
Other for treatment response, you can see the other inflammatory markers like CRP, simple CRP, or complement markers only. There is no need of repeating ANA profile after once diagnosis.
As ma'am said, in lupus nephritis, we see if there is any evidence of flare, you see for anti-DSDNA and complements levels.
Sir, my question, you said high titers can have a future flare or future organ involvement. How frequently do you monitor that then?
No, usually...
Because you said that as of now, the patient has high titers, but there is no major organ involvement. We are treating with a mild glucosteroid pulse or something. Do you give pulse in such points or
no, ma'am.
Just
no
an
major
oral
organ
steroid?
involvement, no steroid, no pulse steroid.
So then how frequently do you monitor?
So usually what I do is every 3 months a CBC, LFT, RFT with a urine routine. That's it, ma'am. Or every 6 months I'll add a urine protein create ratio. That's it. Any other manifestation, anyway, the patient will manifest symptomatically. Only thing what they doesn't manifest is a proteinuria. With frothy urine, most of the people may not tell. So that urine routine and urine protein create ratio.
And what about complements, sir?
Complements we don't do, actually, usually, because a patient, we have seen many healthy patients who will have low complement levels as well, but they don't go on to flare. So, so this is big diversified.
Now suppose high titers, low complements, and only a minor organ involvement, no major.
So even then I won't change my treatment, no, ma'am. So that's why I don't monitor complements actually, unless you have I have a disease dilemma. Where is it a disease activity? Whether it is very minute and going for a major organ, like you have 500 or 780 proteinuria, if you suspect in 24-hour urine, and even if the patient, if she's already a patient of lupus nephritis who was in remission, and now 6 monthly proteinuria when I was monitoring had a value of 780, whether I have to increase my immunosuppression or should I wait, I'll just take a call based on the complements or anti-DSDNA at that point.
If it is proteinuria related, please send us, sir. We will treat.
Sir, these falsely low or negative titers may be due to any interfering substances in the serum we are testing for ANA.
Which one, ma'am? Like
say falsely low titers may be due to any interfering substances present in the serum may come as falsely low titers in ANA.
That is why we have to go clinically, madam. That is what we are telling. So if there is a clinical picture, suspicion of lupus, and even though the titers are low, still we have to treat that clinical symptom. So based on that only we see, and I think nobody is doing DSD. You're doing DSDNA titers, sir. That also we do. What we do in lupus nephritis, when patient comes with flare, we repeat complements. Complements are low, we hit hard. Complements are normal because for me, immune complex is getting deposited in the kidney. So if complements are low, means there is systemic immune complex formation. So I will go like that. But in the monitoring process, like as sir said, there might be proteinuria, there might be renal failure. We have already given therapy. Still, we don't know what is the stage. Whether I have to overtreat because the organ is not responding, or I have to stop. For that decision, anti-dsDNA titer and C1q is helpful. So if your titers are coming down and your complements are getting normal, I can relax. Okay, I have time, because everything takes time to get cleared in the body. So we have to give the time to the patient. Over treating is also a problem here based on your titers or complements.
Thank you.
So no
Thank you,
doubt
sir.
actually. If it is a patient you are suspecting SLE, but ANA profile is negative because what study shows ANA profile for SLE 98% is positive. If ANA profile is negative, anti-Smith body is positive. Is it possible, sir? ANA is negative immunofluorescence, but anti-Smith body is positive. Is it any possibility?
Then you have to see for the techniques. Previous
that's-
technique, you have to see how it was done, how much is the incubation period, that anywhere it was exposed to any temperature fluctuations. These all things we have to see. And ideally, in that scenario, I would repeat an NAIFA again, sir, if I want to see it in an institute setting. Here, I won't do it.
We have to repeat the test.
I repeat the ANA by IFA.
Then again, we have to repeat by another technique, or we have to check and we have to see if you want a confirmation. Because nowadays everybody is over smart and the chat GPT answers most of the questions. So we are left to answer chat GPT. So that is the problem. So it is most important to establish diagnosis also. Previously we can treat, but now I think things are getting difficult for everybody.
Because ANA IFA, if you see the procedure, no sir, it is very much like labile with the temperature as well, very much labile with the ambient lighting as well. So it gets, if the technique has not been done properly, in that cases you may get false negatives. So we had that problem. So whenever we get a new batch of slides, batch numbers, depending on the batches also will have a problem sometimes.
So ELISA versus immunofluorescence.
So that's what we were discussing, sir. So ELISA is like you see Pawan Kalyan only the eyes.
Yes, sir.
So if you see whole picture, like you see anti-cell antibodies, everything. So ELISA is done only for a known antibodies.
Okay.
Like if you have seen the ELISA, that ANA profile, you have seen ANA profile, no sir, 18
Yes.
antigens. So what they do in ELISA is these 18 antigens, they plate onto a single plate. That's it. So if they plate differently, some antibodies may not be expressed. That epitopes would have changed. That's why ELISA, what happens is that you get false negatives. So that's why you have to have a IFA as a gold standard.
Okay, thank you.
And now with the technique what we are having and the less number of titrations if you use, the effective cost of ELISA and ANA IFA is same, sir, unless if you go for higher dilutions. That's what I wanted to reinstate the point, that if you go a higher number of dilutions, the cost of your IFA will increase. IFA done by Metropolis is 3,400. IFA done by Vijay Medical Center is 1,200. This is just because Vijay Medical Center just uses a dilution of 1:80. That's it. Metropolis goes up to endpoint titration. So that's why there is no point in going for titration, sir, for your diagnosis.
So which one is advantageous, sir? IAF or multiplex ELISA? for
Multiplex
detecting-
ELISAs is not like you do multiplex ELISAs only in case of ANA profile, ma'am. That's it.
Okay.
Like for ANA, IFA to screen for sensitive tests, you just need a gold standard is a IFA, ma'am. Multiplex you do when you would have seen reports of ANA profile having quantitative ANA values, ANA profiles. Like you have 12, 15 written, rather than some medical reports showing, reports showing +1, +2, +3, This 1 + 2 + 3 are the solid phase immunoassays, whereas the titer what you get quantitative ELISAs are the multiplex assays. So there's no difference, ma'am,
Okay, there
actually.
is not it.
So I have done my thesis on multiplex assay.
Okay.
So mine is a mycetis profile where I have seen for several other interferon pathways. I have done a multiplex PCR, this assay.
Thank you, sir. Thank you very much. Ma'am, this is for you. Does the magnitude of an ANA titer correlate with the degree of kidney injury, and how heavily does it influence the urgency of a renal biopsy?
So actually, we go renal biopsy based on clinical picture. We don't
Okay.
see whatever ANA titers or whatever we talk. They are supplementary to us. They are not more more diagnostic of this. But if the clinical picture, if it is, you can understand by seeing there are, whenever what they have done is the degree of renal involvement in lupus, they have classified based on histopathological involvement. So you have 5, class 1, 2, 3, and 4 and 5. So in that you have some diseases which have maximum proteinuria, some which have maximum hematuria and proteinuria, and some which have only proteinuria. ఈ 5లో అలా వస్తాయి. So ఇందులో what we do is a minimal renal involvement any lupus patient, because lupus nephritis is present in 50 to 60% of patients, and 50 to 60% of patients who present with lupus nephritis will have SLE. So it's a retrospective. So you are diagnosis based on lupus nephritis, that you are telling this patient might be lupus in the future and might develop extra renal complications also. So presentation is renal involvement is first in 60% of the patients. So based on that biopsy only, we can diagnose lupus and order an ANA titer. So sometimes it is retrospective. We don't go prospective, we go retrospective. So that is why if there is a minimal proteinuria of 500 or any RBC more than 5 in an unspun sample, you have to do biopsy. Or any rise in creatinine for any female. Usually these are the indications where we prospectively go. A lupus patients, these things are there, you do a biopsy. For me, the patient will present either with a nephrotic or a nephritic picture. And I will do biopsy, and the biopsy will tell this is a lupus, please check your ANA titers, please check your DSTA. Okay, this is one aspect. Second aspect is a patient with lupus nephritis, I have diagnosed, I am treating, activity is high, comes with a flare. So my flare diagnosis is again based on clinical manifestations and urine examination. Again, I do a biopsy based on clinical manifestations. I don't go by dsDNA titers or ANA unless the patient is a class 4, which is the maximum class, and you have already given maximum treatment of induction. Still the patient is not responding, then we can correlate with this titers and complements.
So it does not influence the
directly. We don't do that.
We don't.
So clinical picture only will influence your biopsy.
Okay. Thank you, ma'am. Sir,
sometimes what happens is this dsDNA titers and complement levels might be low, kidney involvement might be minimal. So this is confirmed only with your biopsy. So that means the patient is having an extra renal flare and a minimal renal flare. So this does not judge my treatment. As a nephrologist, I am bound to treat that extra renal flare, but I don't treat it as a very life-threatening organ involvement there. So I will go with rest immunosuppression only. So it doesn't correlate exactly with biopsy. That's why.
Okay. Thank you. Sir, till now we have learned that a positive ANA alone does not confirm the autoimmune disease. So what clinical criteria and confirmatory biomarkers are needed to establish a definitive diagnosis?
Clinical criteria depends upon American College of Rheumatology. The criteria is there. Simple juvenile rheumatoid arthritis. If it is, first of all, clinical criteria is less than 16 years. If it is oligoarthritis, less than 3 joints. Polyarthritis, more than 5 joints. With systemic juvenile arthritis, fever, unexplained fever more than 6 weeks, with hepatosplenomegaly with lipidopathy. Is there, you can suspect systemic juvenile rheumatoid arthritis, or only joint involvement with oligoarthritis or polyarthritis. It is important because of the juvenile rheumatoid arthritis mostly associated with uveitis. That is important actually. Uveitis will start before symptoms of arthritis. That's why ANA important in juvenile rheumatoid arthritis. In SLE, that is important because of the high sensitivity, 90% sensitivity SLE. SLE, what your pediatric, most of the pediatric presented with unexplained fever, with cytopenias, with hepatosplenic, sometimes hepatosplenic, skin, joint, and kidney involvement. 3 with skin involvement, malar rash, joint pains with cytopenias, and sometimes autoimmune encephalitis and nephritis. If it is any, then we'll diagnose some autoimmune disease. And otherwise, in Raynaud's phenomenon, it is rare pediatric age group. Mostly, we'll see juvenile rheumatoid arthritis in SLE. That is clinical criteria important.
Criteria. So, any specific antibodies for diseases?
That depends upon what you're suspecting. Routinely, we'll send, once ANA is positive, we'll send the ANA profile. Depending anti-Smith or anti-DS for SLE, anti-RNP for mixed constitutive disorder, anti-SLE 17 for Sjogren's syndromes in the scleroderma. Specific antibodies will send according to the clinical profile.
Okay.
That is because what we are telling is ANA positive or negative. Next you will send for first of all, routinely what you're doing is same time you will send ANA with ANA profile.
Okay.
Better to send ANA first. Once ANA
Then,
positive, then can send ANA profile is better.
Okay. Thank you, sir. Thank you very much. And to Sai Kumar, sir, how do you approach ANA results in your practice? Could you share your thoughts, sir?
So, depending upon the clinical features only, ma'am. Like
Okay.
predominantly, if like I get patients who are frankly rheumatoid arthritis with high titer rheumatoid factor anti-CCP, they'll have deforming arthritis, but still their ANA is positive. So in those patients, I will not go and do an ANA profile, because those patients, even if I do an ANA profile, if they don't have any other organ involvement, which we do at initial baseline workup, so if they have a single organ which is deforming arthritis, which is confirmatory for rheumatoid arthritis, I don't go and work up. So if it is a frank SLE or systemic sclerosis or Sjogren syndrome or any other, so we'll treat accordingly with an ANA values. Like you get surprised sometimes, like you see patients with ITP, idiopathic thrombocytic venous purpura. You'll have ANA positive, but they don't have an ANA profile positive. So these patients are called early phase autoimmune diseases whom are at risk for evolving into a connective tissue disease. So there's a study where they have followed these all ITPs with ANA positivity. At end of 10 years, 40% of them have evolved into an SLE or any other autoimmune disease. Even it can be a mixed connective tissue disease or a Sjogren syndrome. So in these patients, I'll just label them as idiopathic thrombocytopenic purpura with ANA positivity. So subsequently, if they develop any other feature, we'll treat it. So other than this, depending upon the clinical features itself, nothing else.
Okay, sir. Thank you, sir. Ma'am, what is the role and the limitations of immunofluorescence in nephrology, ma'am?
So this I already told actually. So what we do is we do a biopsy.
Mhm.
Biopsy we send two things: one formalin sample and one normal saline sample. We take tissue biopsy, two samples we send. So in the formalin, what we do is we assess the cellularity and structure. So you can have how is the endothelium, how is the glomerular basement membrane, how are the other things, how are the capillaries, everything you can see. So you based on that you will be given certain patterns like a diffuse proliferation or a segmental proliferation or a mesangial proliferation or an endothelial proliferation. So it will tell you what part of that nephron structure is involved and what is happening, how is it causing your clinical picture. That is what happens in your light microscopy. To confirm if it is an immunological mediated disease or not, we have to do a tissue of an immunofluorescence on the tissue. So that is IF. IF, what we do is we do for IgM, GA, and C3, C1Q. These are the 5 things which we see. So presence of C1Q will tell you it is a systemic immune complex disease. And then whether it is lupus or cryoglobulinemia or something, we have to work up based on that. It will tell you there is a systemic autoantibody which is causing a systemic disease. So you have to identify presence of C1Q in your biopsy. IgA, if there is predominant IgA, then IgA, it is an IgA related disease or IgA nephropathy. So IF will tell you what kind of your immunological disease it is. If there is predominant C3, C3 means it's C3 type of disease. So complement C3, indirect pathway, alternate pathway complement disease. So based on that, you have certain etiologies. Why can't we diagnose this on LM? Because all these etiologies will have similar pathologies. So crescent could be because of ANCA, could be because crescent is an LM diagnosis. It is a light microscopy diagnosis where you have a crescent. That crescent, whether it is ANCA, where you have immunofluorescence negative, or whether it is immune complex mediated IgA, you will have IgA positivity predominant. If it is SLE, you will have all complement, all immunoglobulins positive, which is full house predominant. And if it is cryoglobulin, again you can have full house. If it is MPGN, you can have. So your clinical picture is one thing, but to read that biopsy, IF is most important. Because if you don't have IF, you have a crescent, you don't know whether it is ANCA vasculitis or immune complex, you're unnecessary, you'll give treatment for something. So IgA is one disease which can affect all parts of your glomerulus. So it can also present with crescent. But if there is no IF, you think it is ANCA or something and you overtreat the patient. So this is not needed. So this is so your IF will tell you what kind of an immunological disease that is. If IF is negative, that means it is a non-immunological disease. So you have to look for malignancies or secondary infections, something like that. So all these things will be decided on IF.
Thank you, ma'am.
And
That's
if it is
all.
an anti-GBM disease, you will have a linear staining pattern. So it's much more specific. IF will help you to identify your LM pattern much more specifically.
Thank you, ma'am. So that's all from my side, ma'am. I'll invite any questions from the audience side. If you want to ask anything, you can ask. Thank you all experts who participated in the debate and enlightened us. Thank you very much, sir. So I'm closing the debate at
Thank
this
you.
point. Thank you.
Okay, with this we complete our morning session. Now we'll break for lunch. Those who all registered workshop participants, please finish your lunch as early as possible and gather in VDRL block. VRDL in oncology block, first floor. Rest participants will come here for next auditorium session, which will have an interactive quiz session.